Hello, my name's Jenny Langley, and this session is aimed at parents and carers looking at the relationship between self-harm, body dysmorphia, and eating disorders, which very commonly all occur together, with lots of practical tips on how to support your loved one. Okay, we're going to cover a lot in this session. So first of all, looking at the interplay between eating disorders, body dysmorphia, and self-harm, looking at the main types of eating disorder, and then just thinking about our instinctive caring responses when a young person is struggling with an eating disorder and the many related behaviours that come along with that. Resisting the fix-it urge, we all have a righting reflex. So we're going to do a couple of exercises just thinking about why just saying to the young person, you just need to stop, or arguing with logic is unlikely to be effective. Thinking about the cycle of change. So sometimes we see a huge amount of resistance from young people struggling with eating disorders and the related behaviours. And then how can we adapt our response depending on where our loved one is in that cycle of change. Thinking about the different features of body image distress. So in society, many people worry about their body image, don't they? And then what is the difference when it's actually a diagnosable mental health issue of body dysmorphia? Thinking about what do we mean by self-harm, and self-harm within eating disorders might present slightly differently than in somebody without an eating disorder, and thinking about why do young people adopt self-harm as a coping strategy. Then really thinking about practical communication skills. So for me, this is like the most important part, really. So how to approach a young person if you think they're self-harming, because obviously that can be a very difficult conversation. How to respond to a young person who tells you they're self-harming. Thinking about all the way through this presentation about medical risk and emergency first aid. So, one of our main caring roles is preservation of life and making sure that we step in when our loved ones need it. So what do we mean by medical risk? Then we'll be thinking about when your loved one is ready to make changes. We've got a very simple 5-step model that you can have a think about. And then finally, thinking about some of the harm minimization techniques and exploring healthy alternatives. And right at the end of the presentation, there's lots and lots of resources that you can go away and have a look at. Okay, this is my family. So I've been supporting teenagers for many years. So the eldest is now 35. So the young man on the left-hand side in the black shirt, he struggled with anorexia when he was 12 years old. As you can see, he's made a full recovery. So I'll tell you a little bit more about his story as we go through. And then we've got all the way down to Katie, who's actually just finishing her degree. So this photo is a few years older, but really helping you to kind of, with my son's story, helping you to understand how these things can all kind of interplay together. Okay, so a little bit more about me. So this was my son, age 12, before the eating disorder emerged. And then very quickly, he had a growth spurt and he started doing weight-bearing exercise, which seemed entirely appropriate for a healthy, sporty boy of this age. But what happened was he was doing a lot of secretive exercise that we didn't know about, and he wasn't eating anymore. So he was still eating the same as his friends, but he wasn't eating enough to make up for all of this secret, obsessive, repetitive exercise. So you can see the red line there shows his rapid weight loss, and he was diagnosed with anorexia nervosa. This is just a pixelated image of his weight loss. And then this is him, age about 14, coming out the other side. So fully physically restored, maybe still a little bit in terms of boosting his resilience and helping him to think about what might trigger relapses in the future. So that in a nutshell is our journey. With his permission, I wrote this book called Boys Get Anorexia Too. And the first half is kind of like a self-help guide for parents who might be worried about a son who's developing eating disorder related behaviours. And then the second half is literally a diary of the story. So he was an inpatient for 4.5 months. Then he came home, and it was about a year, maybe a year and a half of being back in the community at home, getting back to football until he was discharged from the community team. Okay, I decided to retrain. So I was a city stockbroker. I'm a chartered accountant by profession. I decided to retrain, and I retrained with the team at the Maudsley, who were just happening to be doing some research on a carer support model. And the hypothesis was, can we teach lived experience carers like Jenny to deliver this model in the community? And the answer was resounding yes. So I've now been delivering carer skills workshops for about 15 years. So I've seen, all shapes and sizes of families. I've seen, people caring for loved ones with eating disorders in isolation, but also with self-harm weaving in, and with all of the other mental health issues that can come alongside. So rather than doing a PhD, I decided that I would lead on a carer skills manual. So this manual now was published in 2019, and it was really seen as a useful tool for bridging the gap between families and professionals. So lots of families buy this book as well, but you don't have to buy the book because all of the worksheets are downloadable from my website. So you've got the link there. And I've made videos and podcasts to go with all of the core exercises. So any of the practical tips that you hear today, you can basically go back to my website, and there's many, many more examples that you can look at as well. And there's also a YouTube channel with some other videos based on different situations. So there's one about compulsive exercise, one about going to the supermarket, one about meal support, one about granny's birthday, and so on. So lots and lots of vignettes that can be really useful to illustrate the skills that we're going to share with you as well. Just a disclaimer about the new Maudsley approach, because it can be confusing, because the Maudsley Hospital, it sounds like it's a treatment, doesn't it? But the skill set I'm going to share with you is basically a toolkit for you to support your loved one. And we'd always, recommend getting professional help if you can. Now, it's not always easy, is it, to get that professional help? But if you can get professional help, so your loved one is having their own treatment program, and then this gives you like a toolkit that you can use alongside their treatment program. Okay, so as such, I'm not a medical doctor. I can't give, specific therapeutic or dietary advice, but I can share this amazing toolkit that we developed through that research program. Okay, so this is what we're talking about today. So we're going to think about eating disorders, then body dysmorphia in a bit more detail, and then the real link between self-harm and both eating disorders and body dysmorphia, because very often they all come together. So this is a very common situation where a young person might present with all three, and at the core of this, there's probably very high levels of anxiety in the background. And somebody might present first with their eating disorder and then develop body dysmorphia and then use self-harm as a coping strategy, or they might have anxiety as a child. They might be using self-harm as a coping strategy before their eating disorder and their body dysmorphia develops. So everyone is unique. So we take a very person-centered approach when we're thinking about supporting a young person. Okay, lots of coexisting difficulties that are very common with eating disorders. So anxiety and depression, obsessive compulsive disorder, and then body dysmorphia is like a part of the whole family of obsessive compulsive disorders. So there's a hospital at the there's a clinic at the Maudsley specifically for body dysmorphia within the framework of the obsessive compulsive disorder clinic as well. Compulsive exercise is really common. So with my son, that was a real core feature of his eating disorder. Self-harm, as we've already established, can very much come alongside eating disorders. Often there's people are perfectionist in nature who develop eating disorders, not always, but then the eating disorder will amplify that perfectionism. So the person feels they're never good enough. And of course, that can really feed into low self-esteem. And we see a big overlap between autism or neurodivergence and eating disorders as well. And then sometimes personality disorders. Now, this session is not about diagnosing any of these things, but we're just thinking about the interplay and how we going to support a young person who might be struggling with any of these. Now, what we know is that the earlier, I've put diagnosis here, but the earlier symptoms are recognised, the quicker the recovery is likely to be, because we can step in as the adults in our young person world and really start to support them to even think about the tiniest possibility that maybe change is going to be useful. And eating disorders and self-harm and body dysmorphia can be treated in the home and the school setting if they're caught early enough. So my son ended up having to be an inpatient. His decline was very rapid, but often young people will get support in the community. So, it's not a self-fulfilling prophecy that there has to be inpatient treatment. Now, some of the research that's quite interesting. So there was a huge study done by Bristol researchers looking at the link between self-harm and disordered eating in young people. So it was done in May 21, so kind of 1 year through COVID. And they concluded self-harm and disordered eating are two of the most common consequences of mental health disorders across the globe. And unfortunately, they do often occur together, likely because of similar risk factors. They might be personality traits like impulsivity, maybe always emotionally sensitive or dysregulated, and maybe dissociation when they're feeling very, very anxious from the world around them. And that can develop into other psychological disorders. So the study was huge. It was over 3,000 females and over 2,000 males. And they were evaluated once when they were 16 years old, and then a second time when they were 24 years old. So it's called a longitudinal study, isn't it, when it's over a long period of time like that? And this is the infographic that they created. So 2/3 of females aged 16 reported some form of eating disorders when they also self-harmed. So really seeing a link between those two. At age 16, 24% of males who reported disordered eating had additionally reported self-harm in the past year. And at age 16, the most common form of disordered eating was fasting for females and binging for males. So that was just the findings, but really seeing a close relationship between the two. And then thinking about, some of the stereotypes around eating disorders, people still think about, white Caucasian females who develop eating disorders. So there's been a lot of work going on to raise awareness about the plight of men and boys. So obviously I wrote the book Boys Get Anorexia Too, and these are two other books that are really useful as well. So there's been lots of research showing how males can struggle with body concerns as well. So John Morgan, who I know very well, he wrote the book The Invisible Man, which was all about eating disorders, compulsive exercise, and this body image kind of bigorexia, they called it, because of the desire for young men to be more and more muscular, rather than often with women, it's desire to be slimmer and slimmer. Okay, so younger men are becoming more vulnerable to disliking their bodies, seeking to reshape them, often hours and hours and hours in the gym. Okay, males may be less likely to disclose mental health difficulties and to access support for eating disorders. Why is that? Well, the stigma of having an illness that stereotypically is more often linked to young women, it manifests slightly differently in males. They might not recognize it themselves. And also, there's under and misdiagnosis. So a GP might not be looking for an eating disorder in a male. Certainly with my son, he underwent so many different physical tests before he got the diagnosis of an eating disorder. And then there used to be this age-old statistic that said only 10% of people with eating disorders were male, but we know that that's a massive underrepresentation. So more recent research suggests that between 20 to 25% of young people with anorexia are male, higher than that with bulimia, so 40 to 50%. Binge eating disorder is about 50-50. And then ARFID, which is avoidant restrictive food intake disorder, often overlapping with autism, again, is 50% plus male. So with the younger population, it might be more boys than girls that we see coming forward for support. Okay. John Morgan, and another couple of quotes from John Morgan. So younger men are becoming more vulnerable to disliking their bodies and seeking to reshape them. So that concept of bigorexia and building muscle. And in a school and college situation, male students may be less likely to disclose mental health difficulties, and therefore they're not going to be able to access support for their eating disorders. Then let's think about the LGBTQIA populations. So some statistics here, which you might find really interesting. So as early as age 12, gay, lesbian, and bisexual teens may be at a higher risk of binge eating and purging than their heterosexual peers. Gay males are thought to represent 5% of the total male population, and among males with eating disorders, 42% identify as gay. So you can see that there's a high prevalence of eating disorders in gay young men compared to heterosexual young men. Okay, a little bit more from some research. Gay males are 7 times more likely to binge and 12 times more likely to purge than straight males. And in a survey of over 1,000 LGBTQIA population from people aged 13 to 24 years, 54% had been diagnosed with an eating disorder and 21% suspected that they might have one. So you're seeing a real feature here within that community. Okay, and then, in terms of the distress that comes with being LGBTQIA in a world that stereotypically is heterosexual, then 96% of those who've been diagnosed with bulimia have considered suicide, 92% of those who've been diagnosed with anorexia have considered suicide, 86% of those who've been diagnosed with binge eating disorder have considered suicide. So really high rates there. And 85% of those who've been diagnosed with another eating disorder have also considered suicide. So we really need to be aware of suicidal ideation within this population. Now, in terms of autism and eating disorders, so again, there's a higher prevalence in the world of people with autism than in neurotypical. So we know that 70% of children with autism have co-occurring mental health difficulties, such as anxiety, depression, and OCD. We also know that young people with eating disorders are very likely to struggle with those co-occurring mental health difficulties, and up to 35% of adult patients with eating disorders were found to have autism or present with high levels of autistic traits. So autism in adults is often undiagnosed until after the eating disorder diagnosis, and we've seen a lot of this since the big piece of research that was done at the Maudsley called the Peace Pathway, looking at autism in the world of adults with anorexia. And then this was replicated by another piece of research in Oxford that basically is called the Bob's Peace Pathway. And that found that actually it was higher, that 48% of children and adolescents with eating disorders were found to have autism or very high level of autistic traits. So there's a real interplay going on there. Now, the podcasts I mentioned, so we've made 2 seasons now of the podcasts, and I've been doing these in collaboration with an Irish charity called Bodywise. And the second season is all about the interplay between autism and eating disorders. So you've got the link there at the bottom, but I thought it might be useful just to show those. Okay, now let's just remind ourselves then of the different types of eating disorders. And the wonderful thing about the new Maudsley model that we use as our basis for our practical skills is it's totally transdiagnostic. So it doesn't matter what diagnosis there is, because there's always the same 3 aims when we're supporting someone with eating disorders. So you've got the ones we've already mentioned, so anorexia, bulimia, binge eating disorder. OSFED is where a patient doesn't fit the exact clinical diagnostic criteria of those top 3. And you've got some statistics there around the features of these eating disorders. And then ARFID, which I mentioned before, avoidant restrictive food intake disorder, is very similar to anorexia, but you don't tend to have the body image issues with ARFID. So there might be discomfort with gaining weight. There might be lots of autistic things going on in the background that might make it really uncomfortable for the person to really embrace change, but you don't have that classic fear of weight gain and fear of being fat that you often see with anorexia and with bulimia. So a surprising statistic is that only around 6% of people with eating disorders are dangerously underweight. So again, we have a stereotype, don't we, that you're thinking about somebody who's very, very, very emaciated as being that is the person with the eating disorder, but only 6%. So there are many, many people out there with eating disorders where they don't visibly look like they have an eating disorder. And that can be a barrier to getting help as well. And then only around 20% of people with diagnosable eating disorders are able to access eating disorder services. So that's why I'm so passionate about doing these sorts of sessions, so that we can equip families with some skills that they can help with to use with their loved ones while maybe trying to keep accessing help. And often families become really the warriors for their loved ones. So, never giving up and keep going back to say, well, for these reasons, I think my loved one deserves to get some specialist help here. Okay, so the 3 main objectives that I mentioned just now. So always, whatever the background of the eating disorder, whatever the age of the patient, whatever the gender, the social, cultural background, there's always the same 3 aims. So the first one is to restore regular eating patterns. Why? Well, clearly, if someone's very underweight, then their body physically needs nourishing, but also it's the way the brain works. So the hypothalamus, which is the plant center of the brain, needs regular food throughout the day to work most efficiently. So every 2 or 3 hours during the waking day, particularly for children and teenagers, it's really, really important. Now, there's several aspects to the restoring regular eating. So the first is sufficient to achieve and maintain a healthy weight. So with ARFID and anorexia, there might be a weight gain program to start with, which is very challenging. The second will be to increase variety. Now, again, the the thinking around this has changed slightly with all the research into autism by saying, well, often people with autism, they have very specific food choices or food rules, which is all about their autism. It's not to do with their eating disorder. So they might have a diet which is not as wide as a stereotypical counterpart, but that's completely okay. As long as their brain is being nourished and their body is being nourished, then that's fine. And then social eating as well. So to help a young person get back on track, we need to support them to eat with other people, maybe starting with the family, close friends, and then in the wider kind of world of, going to school and college and university and going off to the place of work. Now, again, for somebody with autism, that might look very different than somebody that's neurotypical. The second main objective is improving self-esteem. So I've never met somebody with an eating disorder who didn't have very low self-esteem, and it might express itself as, I'm not worthy, I don't know why you bother, this family would be better off without me. And of course, that can manifest into suicidal ideation, which is very, very alarming, isn't it, and concerning. So communication is everything here to really support our loved ones, to show that we believe in them. We call it drip feeding affirmations, so I'll come back to that. Can be a very, very successful way. Or just saying to your young person, you're such a valuable member of this family, or your friends really admire your sense of humour or your sense of justice, and so on. And then the final one is developing healthier coping strategies. So the eating disorder behaviours become embedded as the main coping strategies. And so what we want to do is help our loved ones to be able to move away from that and start to do more healthy things, maybe with their peers or with the family. So with my son, his obsessive compulsive exercise was very much an eating disorder behaviour, and we could help him to visualise how he could get back to playing a high level of football. And then the more he could feel that we've got his back to get back to football, the more he was able to resist the urge for the compulsive exercise. So it's very much chicken and egg in terms of that balance, but we'll come back to that. This video, I'm just going to show you a little bit of this to start with, but it can really help us to understand what's going on inside the mind of somebody who's developed an eating disorder. And we can understand when we listen to this, we can think, oh, wow, if that was going on in my mind, then I would be looking for other coping strategies, which might then tip the balance towards something like self-harm or compulsive body checking, for example. So I'm just going to show you a little bit of this just to give you a flavour.
So let's just start with you. Let's just start with the sense that hopefully all of you had breakfast this morning. And with that breakfast, you got some energy to start and enjoy this day here at TEDx. So a person without an eating disorder enjoys their toast, has a little more jam, it feels pleasure from what they're eating and enjoys the taste and gets on with it. And on you go. But a person with an eating disorder, such as anorexia, when they eat, they experience high anxiety, extreme thought disturbance, and noise. I want to give you an idea of what that noise sounds like.
So you can imagine, can't you, that the person that's experiencing this level of noise in their head, then they might find that, any of their eating disorder behaviors or maybe turning to self-harm or body checking helps to bring down the volume of the noise. So, we can't just say to that person, you need to stop self-harming or body checking, because that is their way of coping at the moment. So we really need to come to where the person is and think, how can we communicate and connect with them to support them to be able to be more resilient, to be able to stand up to that noise in their head. And people describe the voices in slightly different ways. So sometimes it's like the bully there was very loud and, saying you're going to be fat and don't eat that. Whereas sometimes the eating disorder voice can be very friendly. I'm your friend. I'm your only friend. So I've got various different videos. I'm not going to show them all today, but that illustrate how the noise can manifest itself in different ways. Now, this is quite a chart that can be quite useful to use to think if you're supporting a loved one, you know, where would they be on this chart in terms of the relationship they have with food and exercise. So the idea with this chart, that if you're on the right-hand side of the vertical line, then you don't have a diagnosable mental health issue. And if you're on the left-hand side, then you do have a diagnosable mental health issue. If you're above the horizontal line, you're coping well in life. And if you're below the horizontal line, you're struggling, you're not coping so well. So in an ideal world, we want all our loved ones to be in that top right-hand side, don't we? So a really healthy approach to food and exercise, maybe with logical and ethical reasons for individual choices, like I want to be pescatarian, vegetarian, vegan, and so on. Then somebody starts to struggle. So you might notice that food choices are becoming more rigid, more restrictive. The exercise regime is changing. So you start to think, maybe there's something going on here. So how do we bring up that conversation? Because it's going to be super sensitive, isn't it? So we're going to think about that when we're thinking about talking to someone who we think might be harming. Then when they get a diagnosis of an eating disorder, then the eating regime and often the exercise regime has become a complete obsessive compulsive activity. So it's not a choice. An eating disorder is not a choice. It's, it's a way of coping in that moment for whatever reason. So, and then with the right help and support, so it might be therapy, it might be the refeeding program, it might be the family learning lots of skills, returning gradually to more healthy food and exercise choices. And it will be slow, steady progress. So often families say it's like sailing in a stormy sea or like a roller coaster, like being in a roller coaster. So with my son, age 11, he was firmly in that top right-hand corner. There was no sign that he would ever develop any kind of mental health struggles. Age 12, we could see something was up. He was doing more and more exercise. We didn't know how much he was doing, but he started to lose weight. So we kept going to the GP. He was having lots of physical tests. Age 12 and a half, he's diagnosed with anorexia. He's very quickly admitted to an inpatient hospital because he's physically very, very fragile. And then age 13, he's discharged from the inpatient hospital, he's back in school, he's playing football, he's still having support from the community eating disorder services, and then age 14 he's discharged from the community eating disorder services. So that was just his journey. So you might think the loved one you're supporting, where would they be on that continuum? Now, medical risk, it's always really important to keep an eye on medical risk with eating disorders because things can deteriorate very quickly, and this is the main checklist. So if you're going to have one checklist in your mind, this is the one to have, and there's a link on the slides to the wider document behind this. But this one-page checklist is really useful if you're going to the GP or you're going to A&E in an emergency, saying, well, we can see that our loved one is ticking a few of these. And so it says that if you see one of these, you should seek an urgent referral for specialist support. So things like recent loss of 1 kilogram or more for 2 consecutive weeks, little or no nutrition for over 5 days, or acute food refusal, physical struggles with carers over nutrition, fluid refusal or signs of dehydration, and so on. So these might be softer targets than you think in terms of being able to go to the GP or going to A&E and say, I think, we really think that we need help. And it's not just a snapshot in that moment, it's building up a picture. So often carers will keep a diary of what's going on for their loved ones. So maybe they've been to A&E a month ago and then they're representing to A&E and say, well, these are the things we told you about last time. And now we've got this moving picture. So even more essential that we get referred on and get some help. Okay, now let's think about our caring responses. So I was all of these. So Professor Janet Treasure had been working, when I met her, she'd already been working with families affected by eating disorders for decades, for 20 years. And she'd noticed some very instinctive caring responses. And I could reflect back on my experience and say, yeah, absolutely, these were my instinctive caring responses. So the rhino very much argues with logic. Well, I was a city stockbroker. I argued with logic every day and people did what I wanted, buy Glaxo, sell AstraZeneca for these 10 reasons, and they would go away and do it. So the rhino is very logical, and that can be beneficial when the audience you're speaking to is in a logical frame of mind. But very often the person with the eating disorder isn't in a logical frame of mind. Okay, so you can end up having a fierce battle with the person. They might say, you don't understand me, leave me alone, you're the one that's got a problem. Then we have the kangaroo caring response. And again, of course, when your loved one is ill, you want to pick them up and put them in your pouch, don't you? You want to look after them. You want to do everything for them, which is great if they're only ill for a short period of time. We've got, flu for a week or something, then of course we're going to put them in our pouch. But of course, an eating disorder can go on much longer than that. So we need to try to get them out of the pouch as much as possible. So all the time we're thinking about giving our loved one autonomy so that they can learn to become more resilient themselves rather than us always doing things for them. Then there's the jellyfish. So a lot of our model, you'll come to see, is all about emotions and noticing and validating emotions, but the jellyfish has a sting in its tail. So the example I often use is I was called to school to pick up my son because he couldn't walk up the stairs. He was too weak to walk up the stairs. So I get to school, he comes shuffling out, he slumps into the car, and I burst into floods of tears. And he says, Mummy, please don't cry, I promise I'll eat. So I'm thinking maybe I need to cry more. But then, of course, when it comes to eating, he can't eat and then I can't eat, and we'll both end up in floods and floods of tears. Then there's the ostrich, turning a blind eye. Now, sometimes as families, we have to turn a blind eye to some of the behaviours because we need to get on with our day. We need to look after the other siblings. We need to go to work. But if we turn a blind eye too much, then the eating disorder can really take over. Think about that voice in the mind of the person. It's like, well, your mum or your dad or your foster carer, they aren't noticing what's going on for you. So maybe, that would embed the eating disorder behaviours further. Same with all of these are relevant with self-harm as well. And then the terrier, a bit like the rhino, but very persistent and loyal. The family dog, very loyal, very loving, but very noisy. So when I would go into terrier mode, kind of nag, 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 eat more, exercise less, everything will be fine. My son would literally put his hands over his ears and go la, 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 la to zone me out. Okay, now, if any of these instinctive caring styles are working, then we say, well, carry on doing that. There's no point for change's sake. But the idea is if you can feel that you're stuck or it's backfiring, it's just not working, you're not making progress, then the idea is to think about these two animals. So the St. Bernard is really the unconditional love of the family, isn't it? So the St. Bernard has got that lovely casket around its neck filled with brandy or rum or something warming, and that represents your self-care toolkit. So your ability to role model that it's okay to take out time out and look after yourself. And that's really, really hard, isn't it, when you're really worried about a loved one? But also the St. Bernard there is doesn't shy away from the danger. So whatever the avalanche, the eating disorder or the related behaviours bring to the family, the St. Bernard stands its ground, waits for the crisis, the avalanche to pass, and then goes in to support the people, the loved one that is struggling. And then the pod of dolphins is a little bit more about movement. So pod of dolphins swimming along, a young dolphin swims out into the danger zone. And then the idea is that one of the dolphins in the pod, not necessarily mum or dad, but one of the dolphins in the pod will swim outside and gently nudge the young dolphin back towards safety. If it's very murky, then that dolphin might swim ahead for a little bit to show the way, so some guidance, but as quickly as possible coming alongside to gently nudge, and then as quickly as possible coming behind to give that dolphin autonomy to make its own decisions as it makes its way back towards the safety zone. But of course, if the dolphin's going off track, then being ready to just come back in and gently nudge. So it's a bit like a dance. I always thought with my son, it was very much like a dance. So we stepped in when he needed us, but then we stepped back very quickly when I could see that he was starting to move forward and start to become more resilient. Okay, now we've got these two empathy exercises. So I'm just going to do very brief versions of these for the video. But if there's videos on my website of these two exercises if you want to see longer versions. Now, this is all about why it's not helpful just telling somebody to stop their eating disorder behaviors or their self-harming behaviors or to stop body checking. Okay, now imagine in your mind you've got a blue balloon and a red balloon, and the blue balloon very much represents your resilient side. So it's the things that make you happy or relaxed, it's your coping strategies, it's the things you're good at, it's your support networks, it's your friends and family, And it is your resilience, your ability to pick yourself up when you're having a bad day. And then the red balloon is when things seem to be getting out of control. So sometimes you have a bad day and you get home and you feel like an elastic band that's going to ping, don't you? Or a light bulb goes and it feels like a complete catastrophe. So you're really, really on edge, but you can always tap back into that blue balloon. So for me, it might be having a cup of tea, going for a little run or walk with the dogs, maybe talking to my husband, having dinner, watching a bit of TV, having a good night's sleep and a shower. And then the next day, the blue balloon's back to having its upper hand. The red balloon has deflated. Now, since COVID, society in general is more stressed, isn't it? For lots and lots of reasons. So generally in society, the red balloon is more inflated than it was pre-COVID. And we've seen that manifest in more young people and adults presenting with mental health difficulties, and certainly an explosion with eating disorders and self-harm in young people. Okay, so let's think about my son. So age 11 and a half, he had this great big blue balloon, virtually nothing in his red balloon. And he had a growth spurt and starts doing weight-bearing exercise. So it seems great. So it seems like his blue balloon's getting bigger and bigger. But what we couldn't see was the compulsive exercise was starting to emerge. Now, he was doing it in secret, and he was still eating the same as his mates. So it became apparent quite quickly because he started to lose a kilo a week. He couldn't eat enough to make up for all of this extra compulsive exercise. So people were saying, oh, what's wrong with Sam? He doesn't look the same. He looks a bit peaky. He's tired. He's a bit moody. He's not quite so good at football. So we knew something was up. I took him to the GP, but the GP had never met him because he's a healthy young lad, and said, oh, don't mummies fuss. You've got a lovely six-pack. Now, a few weeks later, so after 8 weeks, he's lost 8 kilos. So the GP's like, okay, this isn't right, is it? We need to start doing some physical tests. So he has to stop playing football, so he's really, really sad. He's not well enough to join in with the football team. After 10 weeks, he's lost 10 kilos, so he can't walk up the stairs anymore. He's very confused, so he has to stop going to school, so he's socially isolated. And then after 12 weeks, he's lost 12 kilos. He's rushed into hospital, and then he gets the place in the general adolescent mental health unit. Okay, so going back to when he'd lost 8 kilos and he has to stop playing football, imagine if this is your loved one, which balloon would take more of your attention? So which balloon would you focus more of your attention on? Well, almost certainly the red balloon, because you're terrified. I was terrified what was going on with my son. And I thought that arguing with logic would be the answer, because I'm a logical person. He had always been a logical person. So, darling, you know that you would need to eat more and exercise less and everything will be fine. Nothing changes. So he's losing more weight. Darling, if you don't stop this ridiculous exercise, you're going to end up in hospital. Darling, so nag, 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 nag. I became the terrier out of fear. So I very quickly realized that this wasn't working. His eating sort of voice was getting louder and louder. He was losing weight like there's no tomorrow. So I realized I need to focus back on the person. But I need help for the red balloon. I can't ignore it, but I need to focus back on the person. And a technique that I just worked out myself was I would always say his name. So Sam darling, and then I might notice what's going on with his eating disorder. And then I'd always finish with Sam darling, we love you unconditionally. We've got your back. We're your allies here. We're really going to help you. Okay, so that's why all the mental health charities say talk to the person, not the illness. So you can't ignore the illness, but make sure that when you're communicating with your loved one, you're really talking to your loved one. Using their name is a really helpful practical tip. Now, let's imagine for a moment, what does it feel like if somebody is threatening your main coping strategies? So think about with my son, his main coping strategies were compulsive exercise. And then as he lost more weight, he stopped eating as well. The voice in his head, we called it Rex, got really loud. So he stopped eating as well. So every time I said, you need to eat more and exercise less, it was like I was threatening his main coping strategies, how he was getting through each day. So imagine I'm in a room with you and I give you a balloon and I say, hold it in front of your face and I'm going to walk by you with my pin. What would that trigger in you? Well, in most of you, it would trigger a big fight-flight response. So your heart might be racing, your mouth might be dry, your head might be pounding. It's really, really uncomfortable. Your hands might be sweaty or cold and clammy, really, really uncomfortable. But then as soon as the balloon's popped, that comes back down. It's a bit like a wave of anxiety, isn't it? Okay, so, and we all experience waves of anxiety every day. Now, if those waves continue for about 10 or 15 minutes, that's like a panic attack, isn't it? So we know that lots of young people struggle with panic attacks and we can support them that if they they become aware of the signs a panic attack is rising. Maybe they've got their own strategies that they can use because they can't fight those waves because it's like swimming in a riptide, isn't it? They can't fight the waves, but they can float along the top, bob along the top as if in a riptide. They might have breathing exercises or counting exercises or be thinking about a favorite topic like football teams or something like that because they know that this is a panic attack that's going to last for 10 or 15 minutes. But even though they know, when the panic attack goes away, they still feel exhausted. They need a bit of time out, maybe a glass of water, maybe a 5-minute break, maybe to go outside and walk around before they can get on with their day. But imagine if those waves, those big waves, started from the minute you woke up and they stayed with you all the way through the day until you went to bed. How exhausting would that be? There's not a word big enough, is there? Kind of unimaginable, excruciating, and so on. And that's what my son said after he got better, is that all the time we were telling him to eat more and exercise less. He felt under threat like that. He felt that he was in fight, flight. So really, really, really tense. Okay. Now, he also became very low mood as well. So he could flip from a violent outburst to being almost like a poker face, numb person. And we can understand that more with the blue balloon. So if I put the pin in the top of the blue balloon, so you can just about see the pins in there. So you know what's going to happen, don't you, if I take the pin out? It's going to deflate, but it's much harder to spot than the violent outbursts or the temper tantrums or the swearing and rages that often come with high anxiety. So it's really hard to notice. So I can make an illusion that the blue balloon's getting smaller, but it can feel like the world of the person who's struggling is just getting smaller and smaller and smaller, and maybe people aren't noticing. And I was doing this in a school with 120 15-year-old boys, and the boy that was holding the blue balloon just happened to have had clinical levels of depression. He said, "Oh my goodness, Jenny, it was exactly like that. I felt like my blue balloon was getting smaller and smaller, and nobody noticed." And I said, "Oh, wow, thank you for sharing that with us. Did you get help?" And he said, "No, because nobody noticed. It just got worse and worse. And I ended up having to take loads and loads of time off school. I wish I'd asked for help sooner." So he really related, as somebody who'd had clinical levels of depression, to this concept of his blue balloon was just shrinking, 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 and there was nothing he could do about it. Okay, so we can think about the anxiety and the hot emotions that come with being told to stop doing something, and then we can think about the low mood when you feel like your world is shrinking and maybe the people around you aren't understanding. And then what about all the other emotions? Because it's not just anxiety and depression, is it, that we see with young people who are struggling. So this is what the crap day exercise is. So imagine this is your blue balloon. It's a lovely poster called 50 Ways to Take a Break. And imagine you've had a really bad day and you're heading home and you're already anticipating that that you're going to tap into your blue balloon and do some of these things. Whether it's a cup of tea, glass of wine, whatever it might be, you're already anticipating the dopamine is releasing in your brain. And then you get home and I'm standing there behind your front door. And I'm like, "No, you're not allowed to do any of these things." How would you feel? Well, first of all, you would not like me at all. You would think that, who do I think I am, just telling you to not do your coping strategies. You would feel that I have no understanding of your world. I've got no empathy or understanding for the difficult day that you've had. You'd probably be frustrated, angry, lost, alone, many, many, many different cocktail of emotions. And my son said as well, when he got better, he said exactly that. He said, "Yeah, I felt like that I was just feeling all of this cocktail of really difficult emotions. Nobody understood. People just kept telling me to stop. It was excruciatingly painful." And the word he used as a 12-year-old was, he would always say, "I'm bored." And often young people do that when they're trying to describe the emotional distress that they're experiencing. So the idea of these exercises is that we really help you to see the world through the lens of your loved one. So that doesn't mean that you're agreeing with their behaviors. And it doesn't mean you're going to ignore their behaviors, but you're trying to experience some of what they're experiencing, and then you can have a lot more empathy to connect with them. Okay, now moving on to one of our second areas of kind of a bit of psychoeducation is this concept of stages of change. Now, when somebody is struggling with something, particularly with an eating disorder, often with self-harm and body dysmorphia as well, they're often in what we call pre-contemplation. So think of this young man, James. Maybe he's taking anabolic steroids, which is an indirect form of self-harm, isn't it? And he's seeing lots of benefits from taking anabolic steroids. He's bigger, he's stronger, he's faster on the rugby pitch, lots and lots of reasons. So if somebody says to him, "Well, you need to stop taking anabolic steroids, he will just resist. He'll say, no, I'm fine. There's nothing wrong with me. He'll probably say, I'm not taking anabolic steroids. So you get that resistance. Very, very common with eating disorders. And there's two types with eating disorders. So one form is called anosognosia, where the person doesn't even know what you're talking about. So when I first said to my son, you need to eat more and exercise less, it was like I was speaking Japanese to him, because he had not one thought in his brain that there was anything wrong. And in fact, he would say to me, Mum, you need to eat less and exercise more. I'm much more healthy than you are. So when someone's in pre-contemplation, if we as an adult are in action, that can lead to a lot of miscommunication. So we can be trying to pull or push our loved one too quickly. So the idea is we come alongside and we connect with our loved one wherever they are in that cycle of change. Easier said than done, but I'm going to give you some ideas of how to do that with lots of examples. Then maybe we've got Tice, who's in contemplation. So Tice is in two minds about making changes. So part of them wants to stick with their behaviors, part of them wants to make changes, but this can be quite a fragile time. And often as adults, we're tempted to try to push too quickly for change. So we're going to look at a technique called the decisional balance that can really help us to understand roadblocks for somebody like Tice, who's in that stage of contemplation. Then let's say Hayley is in preparation. So she's thinking about making changes, maybe to move away from her self-harm, but that doesn't guarantee movement. So, but the fact that she's thinking about it, we can start to have conversations with her to help her kind of create her own roadmap. Again, not pushing too quickly. And then let's say Chloe's in action, but is struggling maybe with the reaction of her friends to maybe her self-harming behaviors. So the idea is we're always trying to come alongside our loved one and walk alongside, communicating in an appropriate way. And of course, the real version is not like hickory dickory dock, the mouse ran around the clock. It's more like this roller coaster. So your loved one might be going backwards and forwards. So again, it's like a dance. We need to be flexible when we're communicating with our loved one. Now, if we're pushing for change too quickly, often you'll get that kind of shut door, leave me alone, I don't want to talk about this. And we can then reflect, maybe they're not as far around this cycle of change as I thought. So maybe I'll just go back a bit with some of those techniques that we learn in this presentation. Okay, let's dig down a little bit more with body dysmorphia. So body dysmorphia is part of the family of obsessive compulsive disorder. So there's a UK government guideline, the NICE guidelines on this. So I've just put the link in there. And I'm not going to read out these slides, but I've just put them in for reference for you. So this is just a few of the symptoms of body dysmorphia. So maybe you worry a lot about a specific area of your body, particularly your face. Maybe you spend a lot of time comparing your looks with other people's. Maybe you look at yourself in the mirror a lot, or maybe avoid mirrors altogether because you just feel that you're too flawed. Maybe going to a lot of effort to conceal flaws, often with makeup, or, covering up with lots of clothes. And skin picking can be very, very common as well. So body dysmorphia is a really serious diagnosable mental health disorder. And like eating disorders, it can really link in with depression, self-harm and suicidal ideation. So this is just saying, really important to go to your GP, but go prepared. So you might find that the resources and stories at the Body Dysmorphic Disorder Foundation can be really, really useful if you're supporting your loved one to try to get some specialist help. It can be really, really hard to get specialist help for body dysmorphia. This is just a short video to kind of give you an insight into the world of somebody struggling with body dysmorphic disorder. Sorry.
I really started thinking about my appearance when I started low sixth because I thought I'll make new friends. But that didn't really happen. Do I look good? Maybe I don't look good. Maybe that's why they didn't talk to me yesterday. Maybe they're not going to talk to me today because I have an infection. The more I saw that I wasn't really making friends in the months that went by, the more the thoughts intensified. And the more I thought, well, they definitely must not like me because I'm ugly. I'm ugly. Features of my face feel really distorted. It's almost like when you look at an object for too long or when you say a word too many times, it really feels wrong or looks wrong, and that's what my face felt like. The more I looked in the mirror, the more I could find something wrong with it. I would just inspect my face. I would just spend minutes and minutes and minutes, 20, 30 minutes looking at my face and obsessing over every single detail. Even if I had a scratch, to me it would be humongous. Even though to my mom or my friends it would be like seeing a normal teenager, to me it would be like seeing sort of an abnormality and something like an abomination in some way. I started putting more and more and more makeup on. The best description would be like a Ken doll, because my face was really one color and it kind of looked like plastic. Even with all that makeup, even with all that reassurance from mom, I still remember feeling incredibly bad and incredibly ugly. It was just devastating. Throughout the school day, I would just ask for toilet breaks. I would just stare in the mirror and just reapply makeup, or just try and style my hair in different ways. I would just look down and not look at anyone, because I felt like if I just kept a low profile, they wouldn't acknowledge me and they wouldn't acknowledge my face and my imperfections. Eventually, I had to stop going to school. It was too many interactions, too many people. On the journey there, on the journey back, it was just too much for me. That wasn't enough. So I just had to start wearing a hat and a scarf or a balaclava on some days, so that my face would be completely covered, only my eyes would be visible. I really loathed the way I looked. Even briefly looking at myself became too much, and so mum had to unmount the mirror from the wall. I even got to the point where I wouldn't let mum or dad look at me. I would eat on my own. I would just avoid any contact with people. On some days, I just couldn't get out of bed the whole day. I just felt really powerless to change the way I looked. I just felt so ugly, so disgusting, that the only way to stop feeling like that was just to stop feeling anything at all. That really put a lot of stress on mum and dad. They didn't know how to help, they didn't know what to do. I didn't really know about BDD myself, but mum was the one that really helped me realize what it was. I remember going to one of the therapy groups, and we were talking about, being brave and taking the leap and doing things that were scary. I felt, okay, I need to do something, and I took off my scarf and hat and I let people see me. It was really the first step in my treatment in getting better. In the treatment, I did exposures. They're tasks in which you get pushed to the limit of your comfort. We'd go out in London, take the tube, go to the park, where I'd let people interact with me, I'd look at people in the eye. The more I did this, the more I felt I could do more. It was kind of a snowball effect, and that really kept the process of getting better going. Now, life is very different. Even if I've noticed something on my face, I can still go out, enjoy my day, have fun with friends, and interact with people. You have to really compartmentalize your illness and separate it from yourself. It's not who you are, the illness. It's just something that's trying to take over you, but you can fight it.
Okay, so that's a really important message, is that body dysmorphia is a treatable condition. And in the animation there, basically this young person is struggling with body dysmorphia in isolation, but often it can occur alongside eating disorders and self-harm as well. But it really gives you an insight into the world of somebody with body dysmorphia. So I'm going to give you a couple more examples as well, of where there's maybe been an overlap with eating disorders and self-harm. Now, this chart's really useful because it shows that there are lots of similarities between body dysmorphia that can feature with an eating disorder, but there's also some dissimilarities when there's no eating disorder in the background. So similarities is the the low self-esteem, being very self-conscious, shame, disgust, anger, anxiety, very common emotions, being obsessed about defects in one's appearance, often with an eating disorder, it's on generally on my size, weight, and shape. But with body dysmorphia, it can be very, very much specific parts. So, you know, the young man saying there were specific things on his face that he felt were really, really distorted. And then with the compulsions, so very common with eating disorders, you see constant mirror checking. So they said, you know, the mum had to take the mirror away. Lots of reassurance seeking about how do I look? Will this make me fat? Endless taking of pictures, covering up the body with lots of clothes, really common with eating disorders, and avoiding going to certain places and activities. So being with peers or being out socially. And then dissimilarities with body dysmorphia in isolation, there's often higher levels of suicidality and more severe depression. So there's obviously been some research on that. But again, very important to get help for body dysmorphia if you can. And the Body Dysmorphia Foundation and the International OCD Foundation can be really, really useful for seeking, you know, what to say if you're seeking help. Okay. Right. So Danny, age 15. So this is an example of a young person where he struggled with body dysmorphia alongside an eating disorder and self-harm. So Danny wanted to be a model. He went to an agency. They told him he was too fat. He developed extreme body dysmorphia. And he was the first young person apparently to be diagnosed as a selfie addict in the UK. So we're very used, aren't we, to young people taking lots of selfies. But for him, it was constant taking pictures. And then the interplay was that he then developed bulimia alongside compulsive exercise. He's now made a full recovery. So we're going to watch a short video about Danny, so you just get that slightly different perspective when it's alongside an eating disorder like bulimia.
I remember the exact day I went from a normal teenage existence to a housebound wreck. Being a model was all I ever wanted to be, and I was optimistic that I could achieve this. The tragedy was, I wasn't ready to be called fat at 15 years old. That day, walking back from the modeling agency, I had a feeling that can only be described as emptiness. I felt I wasn't good enough for modeling or society. Once home, I made a decision to change myself. I was no longer confident or happy with my appearance. When I looked in the mirror, all I could see was a big nose, bad skin, and an overweight figure. As time went on, I became obsessed with the mirror, checking it up to 10 hours a day, exercising, purging, and applying the latest face creams became an addiction I couldn't cope. One night I locked my room and just screamed. I felt so lonely. I had no friends and I was falling behind in my studies. I remember looking at Facebook, seeing people living, and I was trapped, paralyzed by my body dysmorphia. So I overdosed. I remember the flashing lights of the ambulance. The whole event put my life into perspective. I wanted to be happy again. I wanted to beat body dysmorphia. I got help at a hospital in London, which treated my mental illness. And thanks to that treatment, I am still here, sharing the story with you, in hope that if you are suffering, then you seek help. Don't wait until you are in that ambulance.
Okay, so I use this video in schools with the older students to, you know, really get them to think about the different dynamics. So, you know, what signs did we see that suggest Danny had an eating disorder? Well, obviously he was purging in the toilet, wasn't he? What was his other main coping strategy? So we saw him pounding the streets with compulsive exercise. What did he get from these behaviors? So every behavior has a positive intention. So it was his way of coping, wasn't it? Because he had this internal dialogue that constantly told him that he was imperfect, that he was ugly, that he needed to use more and more face creams. So they were behaviors, the purging and the compulsive exercise were behaviors that helped him to cope with that internal dialogue. As we saw in the previous video, it can be helpful to separate the illness from the person. How did he get help? Well, he was treated at the Maudsley Hospital at the OCD body dysmorphia clinic, and talking therapies were really, really successful. And he's a really amazing young man now in terms of all the raising awareness and the campaigning that he does. So thinking about negative body image then, rather than diagnosable body dysmorphia disorder. So negative body image is common in our society, isn't it? So, you know, most of us have times when we're not happy about the way we look. But when does it become concerning? So this is just kind of a checklist that young people sometimes find useful. So signs and symptoms, maybe obsessive self-scrutiny in the mirrors, maybe 100 times a day, thinking disparaging comments about your body and comparison all the time with other people around you, and maybe envy of a friend's body, or maybe idolizing a celebrity or someone else in the media or on social media. And obviously there's lots of photoshopping and editing, aren't there? So lots of people look really perfect when in fact, in reality, they're not. And what can cause negative body image? Well, sometimes it can be one or more significant events. So for Danny, it was going to the modelling agency and being told that he was fat, but it might be the environment. So maybe a gymnast who's constantly chided by her coach and fellow athletes, maybe to lose that little bit of weight. Puppy fat and gymnastics don't seem to really go together. They shouldn't be a problem, but some gymnastics coaches are very quick to tell somebody that maybe they could lose a little bit of weight. And that can develop into a very much ingrained, long-standing dissatisfaction with their body, no matter how thin they become. So that can lead into a restrictive eating disorder like anorexia. And then a question for a young person to ask themselves: so is my perception of beauty distorted from years of media exposure that glorifies a thin ideal for girls and a muscular ideal for boys that's unrealistic for most people? And there's a few, you know, there's some body image programs now that are used widely in schools. So the Dove body image, you know, Dove soap, that Dove body image program has been widely used in schools. And there's several other body image programs as well that schools are now using to really help young people to reflect, you know, how do they respond to the media, to social media? How much time do they spend thinking about how they look and comparing themselves to others? Okay, so again, we can go back to that continuum in terms of body image issues and body dysmorphia. So in the top right-hand side, normal society pressures around body image. So everyone, most people have, you know, parts of their body that they're not 100% happy with. Then dipping below the line, so daily concerns and anxiety around body image and intense fear of weight gain. So that might be a precursor to developing anorexia or bulimia. Then diagnosable body dysmorphia, so it is a diagnosable mental health issue with high levels of stress, anxiety, depression, often coexisting with other obsessive compulsive behaviors. And then with the right help and support, returning to that more healthy mindset around body image, so slow, steady progress. So Danny, age 14, was in the top right-hand corner. Age 15, after he went to the modelling agency, he developed huge concerns very quickly and anxiety around how he looked. He started doing lots of repetitive behaviors. Age 15 and a half, he's diagnosed with body dysmorphia. He's treated at the Maudsley Hospital in London with talking therapies. Age 16, he's back in, you know, back on track with his adolescent development. He's starting to use the strategies that he's learned to become more resilient, because he's got that internal dialogue telling him that he's not good enough. And then age 18, he's emerged as a very robust young man who does lots to raise awareness and support charities around body image and also male eating disorders. This is another true story. So Amy, age 13, she'd been recovering from anorexia at home, and she developed body dysmorphia and crippling agoraphobia as the weight went on. So this is really common with a restrictive eating disorder. As the weight goes on, it's very, very anxiety provoking for the young person, because they're getting used to being in a larger body. The weight goes on in lumps and bumps. It's really very distressing for young people. So the background to Amy: she was a social butterfly who loved performing, before she developed anorexia, it was a very rapid onset, like with my son. She developed extreme body dysmorphia alongside her anorexia, so to the extent that she couldn't go outside the house. So she truly thought that people would be sick or horrified if they saw her. As the weight went on, the agoraphobia worsened, so the fear of being in social settings. The whole family felt completely stuck and imprisoned. So the dad came up with an idea, and this was alluded to, wasn't it, in the animation, where the young person was saying that gradually they were exposed to more different situations, to be brave and courageous to do that. So the dad came up with an idea where he said, is there any possibility, Amy, that we could just go for a drive in the car after dinner when it's dark? And the key thing here was that she could get into the car through the garage. So she didn't have to go outside to get into the car. So she agreed, while mum was clearing up, they could just go and drive around the block. They'd maybe play happy music, or dad would tell a funny story, but there was no pressure to talk. They could just drive around the block. And then gradually they increased it. So as it was coming up to Christmas, the dad said, shall we go to the local villages and see the Christmas lights? So she's safe in the car, it's dark, but they can see the Christmas lights. Then one day he said, oh, it's going to be a lovely sunrise. Shall we go to the coast and watch the sun come up before other people are at the beach? And then gradually more exposure to very quiet parks, then going to a garden centre when there was very few people around, and so on. And within 6 months, she was able to go to the ballet in London with her family. So obviously that exposure. So this was in a situation where the family didn't get specific medical help or talking therapies, but they worked out that they could do this kind of gradual body dysmorphia exposure with their daughter, but very slowly, very gently, at a pace that was tolerable for her. And then with my son, so just thinking about the interplay with him between eating disorders, self-harm, and also body dysmorphia in the latter stages. So the main drive to his anorexia was that he wanted to be the best footballer and win the school cross-country run. And in his attempt to do that, and having a growth spurt, which sends your body sometimes into energy deficit, then he became obsessed with the compulsive exercise. So increased weight-bearing exercise led him into a calorie deficit. So he started losing weight rapidly. He developed lots of extreme obsessive-compulsive behaviors, not just with body dysmorphia, but his whole day was dictated with rules around, everything being just so. So the numbers he had around his repetitive exercise. So, for example, 500 sit-ups, 500 pull-ups before breakfast. Not being able to step on cracks in pavement. So lots of superstitions, walking upstairs with his right foot first, walking downstairs with his left foot first. Like his whole day was dictated with these obsessive compulsive behaviors as his mind became more and more starved. Then starting more and more of the compulsive exercise. And then when he was in hospital, he started head banging. And that was a very distressing feature. But lots of inpatient mental health settings, they seem to be a bit immune to headbanging because it's quite common where patients are very distressed. And so we would go and visit him, and clearly he had been banging his head quite hard, but the nurses and the psychologists would say, look, we're working with him on that, so please don't worry too much. But very, very difficult when you're seeing repetitive headbanging at home. And in a way, it was his way of communicating his distress, as well as quietening that eating disorder voice that we heard earlier. And then once home, this was when the body dysmorphia started to kick in. So he became really fixated on the skin on his face. And he did get, as his hormones kicked back in, so he'd been through a very early puberty, which had gone into reverse with the starvation. And then his hormones came kicking back in. So it was like triple puberty all at once. So he got a few spots, not terrible, but the closer he looked in the mirror, the worse he thought he looked. And so he would start smashing mirrors. So we had to get rid of the mirrors like the mum in the animation, because it was simply becoming dangerous for us to have mirrors in his bedroom. And as you know, he's made a full recovery, and he returned to football, competitive football, soon after his discharge from hospital. So where families can feel really, really stuck, then you can be surprised sometimes that when your loved one puts their mind to moving forward and are getting the right help, they can move very quickly back in that kind of more healthy direction. Okay, there are government guidelines, and the same way as with body dysmorphia, there are government guidelines around self-harm. Now, interestingly, self-harm isn't seen as a diagnosable mental health issue, so it's seen as a behaviour that often coexists with diagnosable mental health issues. So alongside anxiety, depression, eating disorders, body dysmorphia, and so on. So kind of headline, people who self-harm should always be treated with the same care, respect, and privacy as any patient. So if we go back 10 years, often young people would have a very difficult experience if they went to the GP or went to A&E, but that's changed now. There's been a lot of staff training. And then the NICE guidelines were updated in September 2022 and then revised last year in August, and they're much broader now. So all healthcare professionals, so I'm doing a similar version of this video for healthcare professionals, should take account the likely distress associated with self-harm. So the new guidelines are much broader than the pre-existing guidelines that were very dated. Okay, so let's move now. So we've looked at eating disorders, we've looked at body dysmorphia. Let's now move into the world of self-harm and think about some techniques and examples. So a definition of self-harm is harm to oneself in order to cope. So it's a coping strategy. These are some commonly adopted coping strategies, self-harm related coping strategies. So it might be cutting, burning, embedding, overdosing, consuming poison, scratching and banging are really common, punching, hitting and biting, and then indirectly eating disorders, drugs and alcohol. Okay, as with eating disorders, there's generally three main objectives. Whatever the self-harm is, there's generally the same three main objectives. So the first with self-harm is always thinking about physical first aid first. So first aid and then connect with the young person to build trust. Now, the first aid might be physical first aid, or it might be psychological if there's suicidal ideation there as well, but always be aware of that medical risk and be prepared to step in. So is there an immediate need for medical care? Is the young person a danger to themselves? And what message do you want to give that young person? So that's our first step. Then the same as with eating disorders, improving self-esteem. So I've never met somebody who self-harms who hasn't had very low self-esteem. And then the same as with eating disorders, developing healthier coping strategies. So new neural pathways or reigniting pre-existing neural pathways that have been kind of suppressed by extreme anxiety. Okay, now with eating disorders, the self-harm might manifest itself slightly differently. So headbanging, I've already mentioned. Now, the NICE guidelines kind of exclude headbanging, but all of the techniques I'm going to share with you. So this isn't about getting a diagnosis. This is about if you can see your loved one is very distressed, then these are techniques that you can use. So in our world, for the purposes of this presentation today, then we would include headbanging in that. Lots of violent outbursts leading to maybe repeated injury. So think of my son punching the mirror, and that could cut his hands. Interfering with the nasogastric tube. So sadly, many patients are fed for sometimes a short, sometimes a longer period of time with nasogastric food tubes, sometimes under restraint. So again, pulling the tube out or lots of things that young people find that they can do to interfere with that nasogastric feeding. So again, it's kind of an indirect form of self-harm. Trichotillomania, which is hair pulling. So it might be often at the back of the head or eyelashes, eyebrows, very common alongside eating disorders. And then skin picking, again, very, very common both with body dysmorphia and with eating disorders. So we're really building up the picture of this relationship between the three. And then sharp fingernails. So I had a mum whose 13-year-old son was treated as an inpatient. He came on home leave and he had very manicured fingernails, and she thought, oh, they've been doing some kind of lovely, you know, pampering sessions. And basically he was filing his fingernails that he could basically scratch his skin to the extent that it was, you know, harming his skin. Okay. Throat damage from repeated attempts to purge as well. Again, kind of an indirect form. But these are the things that we often see within the world of eating disorders. So which comes first, the eating disorder or self-harm? Well, it's chicken and egg, isn't it? So these are common times when self-harm appears alongside an eating disorder. So it might be waiting for an eating disorder assessment. So maybe you've taken your loved one to the GP, they've said, yeah, we think it's an eating disorder, we'll make a referral, and then you wait months for some sort of response. So the young person might be so distressed, having gone to the GP and they're not getting any help, that might be when self-harm appears. Often it's soon after admission to an inpatient unit, and families are often really distressed by this. They say, well, surely in an inpatient unit, they can stop them self-harming, but it's impossible to make an environment totally self-harm proof. So I remember a young lad who was in the general adolescent unit with my son, and he would go out in the garden and find a sharp pebble or a piece of broken glass or something like that. So very, very difficult. And it's the distress that when the person is admitted, that the dialogue in their head, the eating disorder dialogue, can really get turned up. So that can lead to self-harm. So obviously they're being monitored, but it's very difficult to completely stop the self-harm. As food requirements are increased, so when somebody's on a refeeding program, the food requirements are going to be way beyond what an equivalent person would be eating of the same age and height. So my son was having to have about 4,500 calories a day in the later stages of his recovery. As the weight goes on, so the weight doesn't go on evenly. Often, the patient feels that their stomach is really bloated. They might be getting gastric pain because their gastric motility is slowed down, often around their face. So there can be lots of distress as weight goes on. And just that general fear of weight gain that comes with eating disorders. Moving from different phases of treatment. So I've put here phase 1 to phase 2 of family-based therapy, where the patient is being given more responsibility. Being discharged from eating disorder specialist treatment with little or no follow-up. Sadly, that's common. And often when the person with the eating disorder has gained weight, they've still got a long way to go in their recovery, but everyone around them assumes that they're much better, and they feel like their support network is just kind of dissipating. So that can be when self-harm can appear as well. So again, we can look at this kind of map. So a young person who's wholly content, positive and optimistic, probably not so likely to use self-harm. So in contrast, somebody who's struggling, stressed, not coping well, they may turn to self-harm as a coping strategy. Somebody who has a diagnosis of a mental health condition and feels like they're not coping, even more likely that self-harm is a feature. And then diagnosis of a mental health condition and now coping well, self-harm might still be a lingering feature. So this is what we often see. So sometimes you get pockets of group self-harm in schools. Sometimes it's referred to as contagion, and that tends to be quite superficial. But what schools need to do is, if there's, say, 10 young people who are in this group, and part of the badge of honour is self-harming, then they need to set the boundary that this isn't something that is allowed in school, but then they need to sit down with each individual person to explore what's going on for them. So 9 out of 10 might be really relieved that that's been banned in school, but 1 out of 10 might have found that that's an amazing coping strategy, and they'll be driven underground by this blanket ban of group self-harm in school. So it needs to be treated with care. When a young person is struggling, then yes, self-harm is much more likely. When they have a diagnosis of a mental health issue, it increases in likelihood. Even when they're doing well then, so self-harm is still possible. Often it's a lingering coping strategy. So as the person becomes more resilient to the dialogue about their eating disorder in their mind, maybe they're still using self-harm as a coping strategy to quieten the eating disorder voice. And then for somebody who's back in that top right-hand quadrant, over a period of time, they might learn to completely let that coping strategy go. But it might linger for some time. Okay, so let's just go back to Laura Hill and think about when somebody is weight restored, what does that feel like?
Feeding to help that person who's starving. We used to say, just eat and you'll start to feel better. I don't say that anymore. I now say, you're going to eat and it's going to be painful. When you eat, it's not going to feel good or think good, because as we try to help refeed you, you're going to have increased disturbed thoughts while your weight is restoring, and it's going to be miserable. You're going to have increased disturbed thoughts even when you restore your weight, and you may have that for a good period of time, and that volume of noise never comes down, and in other cases the volume comes down. So the person with anorexia thinks and feels worse when they're at a normal weight. They hit the normal weight and all your friends are coming around, they're going, "Oh, you look so good, you look well." And they are literally living in the noise and the disturbance and the pain of a normal, healthy sized body. So it makes sense why relapse has been so high, because by not eating, I can deaden that pain and get back to work. If you start reframing food, for you, food is socialized, joy, pleasure. But for a person with anorexia, it's like the insulin to the diabetes. It's medicine. Just, I need to take my medicine and I've got some side effects from it. I have to eat my food. So we have been testing and working in collaboration and exploring new research in the sense of, can we bring the volume down of that noise? So maybe we need to pre-plan the food, pre-dose it, and prescribe it so that they know exactly what they're going to eat into. So when you're going somewhere with a friend who has anorexia, you say, just like with a person with diabetes, do you have your insulin? Do you have your food? Do you have a plan? Do you have your food? And so if they know what they're taking and they know the amount, and they know and potentially practiced eating some of that food over and over, the clients report that the noise comes down. May not go away, but then I can hear and function and interact and get through it. So I'm realizing that using the same meal plan is not part of the disease. One of the clients said, it's actually part of the cure. One father got it.
So you might want to go back and watch the whole video. It's really compelling, but that is just hearing a psychologist talk about the challenges in those later stages really helps us to understand why you might get that coexisting self-harm and body dysmorphia as well.
He got it.
Okay. So a few more slides around self-harm before we move into the really kind of more practical techniques. So self-harm can be direct or indirect. So we've talked about eating disorders being an indirect form of self-harm. Compulsive exercise can be an indirect form of self-harm. Self-harm can be transient. So for some young people, it's very short-lived, but for others, it's much longer term. It might be all the time that they're in education. Self-harm is an effective coping strategy, especially for people with autism, maybe who are struggling to fit into that neurotypical world. Self-harm is usually conducted at times of anger, distress, fear, or worry, although it can become habitual as well, is that some young people find that it's just their automatic coping strategy, and it's a way of coping with big feelings, often lots of anxiety and depression in the background there as well. Warning signs, so I'm not going to read all these out, but obviously unexplained injury. Lots of covering up. So we saw that with the body dysmorphia animation as well, didn't we? That the boy was covering up. Sharp objects, blades, scissors routinely carried around, but think about a pencil case in a school. So a pencil case effectively is like a toolkit for self-harm in school. Maybe bloodstains, social isolation, changes in behavior, so maybe sleep or eating patterns, and that low self-esteem that we've talked about. There might be poor performance in schoolwork, but often we see that young people who are struggling with eating disorders and self-harm often are very present in schools. So one of their coping strategies is they just throw more and more time into their academic work. And of course, they can get really good results. And that's a real dilemma for schools, isn't it? Because they want the student to get really good results, but they also want to support the student who is maybe showing signs of an eating disorder or self-harm or body dysmorphia. Lack of interest in what used to be favourite hobbies. And then why do young people self-harm? So this is just a list from the mental health first aid programme. So, you know, there might be lots and lots of reasons, but sometimes there's no obvious reason. So we often talk about adverse childhood events, don't we? ACEs. So many of these would be classified as adverse childhood events, but generally it's when we see young people with low self-esteem, poor body image, often self-harm peaks around exam time, so exam stress, sometimes peer pressure, or often it's to do with peer rejection or maybe bullying. So being seen as that kid who self-harms, other peers reacting badly to scars, things like that, can be really difficult for the young person as well. A few myths around self-harm. So people who self-harm are crazy. Well, that's obviously really, really outdated. Self-harm is attention seeking. Well, in my world, we always say if a young person is seeking attention, it's because they need attention. So let's be curious. Let's explore with them what is going on for them. That means that they need attention. This is an important one. People who self-harm are suicidal. So most people who self-harm say it's a protective coping strategy. And if they didn't have that coping strategy, then they might be suicidal. So it's a coping strategy that reduces any kind of suicidal ideation for many. She chose to start, so she can choose to stop. So again, like eating disorders, self-harm isn't a lifestyle choice. It's a coping strategy that's been adopted because that young person needs a coping strategy. And for them, it's working in this moment. So you can't just choose to stop because it's a coping strategy. And people who self-harm are doing it to fit in. Very small minority, but that contagion example we just looked at in the school setting is sometimes it is being part of a club in a school or college setting. Okay, so thinking about that connecting then. So you suspect a young person is self-harming. What do you do? Now, if you're like me, you'd want to go in with welly boots and say, well, I think you're self-harming. We need to talk about this. And that's likely to be met with a shut door. I'm fine, leave me alone. In the same way that I would say to my son, you're losing weight, you need to eat more and exercise less. Shut door, leave me alone, you don't understand me. So we need to be really patient. I always say carers need to have the patience of a saint, and we need to keep as calm as possible. And that's much easier said than done, isn't it? But thinking, what's our aim here? The first thing is to aim to get the young person to talk. The aim isn't to stop them self-harming. It's not to fix them. We can't fix them, but we want to open this as a safe topic of conversation. And it can be the most difficult step. So once it's out in the open, it's often, we find very quickly that we find our family way of talking about self-harm. People who self-harm are very acutely aware. They're super sensitive to the reaction of others. So this is really, really important. So we're only human, we might be shocked, we might cry, but then it's our response to that, isn't it? So on reflection, I can see that my initial response wasn't helpful. And now that I've been thinking about it, then what you really wanted to say in that moment. And young people need to feel really comfortable with who they speak to. So in a school setting, it's often the young gap year student, for example, because they feel most closely aligned to somebody who's similar to their age. And lots of schools now have, really good peer support networks where the students who are in the peer support team have had training in these sorts of techniques as to how to respond if somebody discloses that they're self-harming. And obviously that peer support person wouldn't then be the only person. They would be signposting the person who's disclosing where to go within that school setting that's going to be safe. So these are things that young people always say are unhelpful. So just simply asking them to stop, telling them that it's wrong, giving a negative reaction. And as I said, we're only human, so we need to reflect if we have given a negative reaction, assuming that every episode of self-harm is for the same reason. So lots of people who talk about their self-harm say that each scar or wound tells a different story. Dismissing their concerns. So say a young person tells you that they've been picking the skin on their thumb. If we respond with, oh, that's not really self-harm, lots of people do that, then they'll go away, they'll feel that they haven't been listened to or understood, and they're likely to adopt more harmful self-harm coping strategies to try to get the attention that they need, or just labeling them as that's the self-harmer. So always think about using the person's name, never labeling them as that's the anorexic, that's the self-harmer. That's really disrespectful to somebody who's struggling in this way. And then what do young people say is more helpful? So offering help. So how can I help? And we don't have all the answers. Often we don't know how to help, but we can give our loved ones more autonomy by handing it back to them. Well, I'd like you to go away and think about this and come back maybe with some ideas of what I could do better. It's a strategy that many families find is very successful. Always saying thank you for telling me. So it's really brave of someone to open up, isn't it, about their self-harm or body dysmorphia or eating disorder behaviours. Thank you for telling me, we really care about you. understanding that it's not just you as the parents and carers who are the person that can support. So always being curious about, I wonder who else in your network could help you. So it might be that they find it easier to talk to somebody who's more similar in age. So whether it's in the extended family, maybe a cousin or a younger aunt or uncle, or maybe it's in that school setting or a sports club, who else would you feel comfortable talking to? Acknowledging that it takes courage to talk about these things. So it took courage to trust me with that. Thank you. So any thank yous are really useful. That it's okay to talk about self-harm, that you don't feel awkward, that, that you can speak about this without any hint of judgment or criticism, and staying calm and not judging. Okay, so these are some phrases that can be useful to open the door to this topic. So we're not going straight in and saying self-harm. So are you okay? You seem a bit down. I've noticed. So whatever you're noticing, your friends are worried. I wonder why that might be. So with these types of gentle curiosity, you're building trust. That's really, really important. And then how do we keep the door open? So lots of families find that if they are responding to a piece of research or something in the media, or an article that has been in the local paper. So I read an article about the impact of COVID on young people, and that there's been a dramatic increase in self-harming behaviour, maybe. What would you say to a friend is struggling? That can be a really useful one. Or what would a friend say to you can also be a useful one to open up the idea that it's okay to talk about these things. And then always that unconditional love, keeping the door open. I'm here to talk if you ever want to, but we don't need to talk about this right now. The only caveat to this is when medical risk is really high and you're going to jump straight in. Okay, so let's go back to James, we mentioned earlier. You've been informed by another parent that James and a few other boys at the gym are thought to have been taking anabolic steroids. When questioned, the boys are adamant that they're just taking protein supplements to build muscle, and it's really helping. You can see James isn't his usual vibrant self, so you're on alert. So we want to keep the door open. We've got to build trust here. Darling, you don't seem yourself. I've noticed you're struggling. I'd really like to help you. If you had a magic wand, how would your life be different? I was never sure about that one, but lots of families said that's a really useful way to sow the seed that you're interested in what's going on for them. It must be baffling. So think when somebody's in this pre-contemplation, it must be baffling for you that we're all concerned. And from your point of view, you're okay. It must be confusing for you when you think we're worrying unnecessarily. So we're trying to kind of keep the door open by engaging in things that James would agree with. Yeah, I am baffled, I am confused, but I'm not ready to talk yet, so we need the patience the same. I've noticed you're tired and out of sorts lately. Okay, and then we have this framework of oars, which is like, think about you're rowing alongside your loved one. So this is from motivational interviewing techniques that we use all the time in the New Maudsley approach. So the oars stands for open questions, affirmations, reflections, and summaries, but it's not a linear model. So it's much more powerful actually to leave questions till the end of a conversation. But just as a couple of examples, I'm wondering what life is like for you right now. How are you feeling? You seem a little down lately. So those are open questions. Yeah, the idea is that they can't be answered with a yes or no, but any open question can be answered with a slammed door. I don't want to talk, leave me alone. You don't understand me. So we have to sometimes put a tin hat on, don't we, when we get that kickback. Affirmations might be about character strengths. So it might be you're so hardworking, resourceful, thoughtful, creative, inspiring, loving, caring, any of those. Or it might just be one of those thank yous. So thank you for trusting me with that. Thank you for telling me how you're feeling. Even if they've said it in a fit of rage, you're the effing worst mother in the history of the universe. I quite often got that kind of outburst from my son. Reflections, just noticing you don't seem yourself. I've noticed you're struggling. I'd really like to help. You seem maybe the emotional bit, overwhelmed, exhausted, distressed. And then every now and then a summary. So not every conversation, but again, we're checking back in with the person. We're really trying to make sure that we're on the same page as the person that we're supporting. I've just been reflecting on what happened last week, what we've been talking about, and I just want to check in and see that we're on the same page, for example. Now, the idea is with this framework that for every one question, we want to be giving back at least 2, if not 3, affirmations and reflections. So think about this. You've got 2 eyes, 2 ears, and 1 mouth. So that's 4, isn't it? But at least 2, if not 3, is a good balance. And I found that really hard to start with. And then I realized actually starting a conversation with reflections and affirmations is much more powerful. And then it helps you to keep the number of questions to a minimum, and also being really comfortable with not having an answer in each conversation. So just leaving a conversation hanging. I'll just leave you to think about that rather than going in with a question. What do you think we should do next? Okay. So pauses and gaps in conversations can be really, really useful. So this approach is very person-centered. It helps to boost self-esteem with the affirmations, and it shows that you're really listening and noticing your loved one's feelings. This is an A to Z of affirmations, so these are character strengths, big words, but often young people say that's too overwhelming, especially when their self-esteem is really, really low. So then you might get this kind of kickback. You're just saying that because you're my mum. Too much pressure to be that strong person. My brain tells me the opposite. You say I'm courageous. I feel like I'm a mouse, you know? So then we have these softer affirmations, and you might find that to start with, these are more effective. We love you unconditionally. Your friends admire your sense of justice. Thank you for trusting me with that, sharing that with me. Thank you for listening to me. Yeah, you're an important member of this family. Those are lovely, softer affirmations to start with. Okay. And then, you know, keeping connected. So this might be going on for a few weeks, which is frustrating, isn't it? But it's really good to build that trust. You're determined and strong, and I'm interested to hear your thoughts on balancing your training and workload. So we're coming to where James is. James has got a real interest in being determined and strong and going to the gym. So we're just being curious about his life balance here. You've become much stronger this term, and I've noticed you're taking your training very seriously. Well, he would agree with that. What would your top training tips be for a younger student? So that's like an indirect affirmation, isn't it? We know that you're really good with the younger students. And then when you've made the connection, I've noticed you've stopped training with your pals, but not expecting an answer straight away. And tell me the things that motivate you, maybe. So think about the red and blue balloons. So you're always seeking to pay more attention what's going well for the young person, as well as very gently noticing what might not be going so well. So more blue balloon, but you're still noticing gently what's going on with that red balloon. Okay, so now we're moving on. The young person has disclosed that they're self-harming. Okay, this is a video by, there's a new website called Sorts, so Supportive Response to Self-Harm. It's aimed at school teachers, but there's lots of resources that you might want to go and have a look at as well. So think about these two alternative responses, and maybe you naturally would be responding in one way or the other, but just have a think of that kind of comparison.
Come in.
Sir, you got a minute?
Yeah, sure. Is everything okay?
Yeah, I guess. I don't know. Been going through some stuff recently.
What sort of stuff? Is it mental health?
Well, yeah, I guess.
You've not done anything silly, have you? Look, whatever you've got going on, doing that isn't going to help. It's just going to make things 10 times worse.
I know, sir. I've got lessons to go to, actually, in a minute, so I'm gonna go. Thanks.
Come in.
Sir, you got a minute?
Sure, sit down. What's been happening?
Well, I haven't been feeling great, if I'm honest.
Can you tell me some more?
I just keep feeling really low, and I've started hurting myself. It helped me not feel so bad.
Thank you, Jack, for being brave enough to tell me. Would you be open to chatting some more? And thinking about who we might need to talk to? So, how long have things been like this for?
Well, I guess at my old school.
School staff are often the first professionals that young people choose to speak to about their mental health needs. To help you feel more prepared for a conversation about self-harm, please visit www.sortsforschools.org.uk.
Okay, so the Sorts website is very new, and it was a collaboration with the Charlie Waller Trust. And then I'm going to show you a couple of older videos, but they're still very relevant today. So this was a collaboration between Young Minds, the Royal College of Psychiatrists, and the Charlie Waller Trust. So I do a lot of work with the Charlie Waller Trust, and there's 3 videos. So one is aimed at the young person, one is aimed at parents, and one is aimed at professionals. So we're going to look at the parents and the young person's videos in this session. Okay, so this is the parent version.
It was shock, it was devastation. It was one of total disbelief. I knew about self-harm, but didn't ever expect it to happen to my little one. And I just put my arm around her and I said, it might help if you talk to me and we try and find, some way of helping you get through this.
My mum felt it was her fault. She was blaming herself for it, so it kind of made me feel bad because I know it's not her. But then to this day, she still thinks it was partly her fault. I don't want to put everything on them. I don't want to be watched constantly. I don't want people to see me as that person.
Trust yourself. Although at the time you think you haven't a clue what's going on, you probably have. Just remember that actually, it isn't actually all about you and you are okay as a parent still. And just keep talking. That is really fundamental.
My mum and my dad came up into my room, and you know what, they did something that was brilliant for me. They had accepted it, they didn't shout at me, they didn't tell me off, and that's exactly what I needed. I just needed that support, and they gave it to me, and I'll be ever grateful.
I think it's really important to have the trust, because if they don't trust you, then they're not going to be open with you. Everything's going to be secret. And then when you know the problems, you get the professional help. It's important to get the professional help.
It was definitely like a weight off my shoulders, because I've always known that these people care about me. I feel very lucky to have a lot of the people around me, like all my friends, my boyfriend, my parents, and other people in my family. That's a very positive thing that has come out of this, being able to communicate a lot more with them.
She's done brilliantly, but it had to be when she was ready, on her terms, and not mine. And that as a parent is hideously hard.
It took some time, but yeah, I have my moments, I have my days. Before I didn't have aspirations, but now I do, and I see a future.
Okay, so a very hopeful video, isn't it? So it's natural to feel overwhelmed with emotions, whether there's a backdrop of eating disorder, body dysmorphia, or self-harm. Our response as parents and carers can be totally overwhelming and kind of the shock. And often carers say that they feel this sense of failure. Why didn't I see this coming? Why didn't I prevent it? Could I have protected them better? And that's just, our human response. You know, emotions are what make us human being. So some of the big emotions that that you might be experiencing, so that shock, total confusion, anger, devastation, shame, sadness, disbelief. Why? Why us? Why our loved one? And so on. So it's really useful to have a think about your own emotional response and then seek to validate that. So I've got a couple of slides here that might help you have a framework to reflect on your own emotions in response to supporting your loved one with any of these issues. So the caring behaviour, I have to watch my daughter all the time as I'm terrified she will self-harm. This is a very instinctive response. The triggers for this, my daughter's recently started self-harming. It was such a shock. It started after she received a diagnosis of anorexia. I cannot understand why she would want to hurt herself like this. I feel it's my duty to protect her. So, you know, very, very instinctive caring response. What's my fight-flight response to this? My physical sensations? Well, we're all slightly different, but maybe my head is pounding. I have this empty feeling throughout my body. I feel sick all the time. And then we can get these automatic negative beliefs. So I'm a terrible mother. How did I let her get this eating disorder? And why can't I stop her self-harming? I've completely failed in my duty to care for her. So often I meet families who feel so disempowered and debilitated. And that's why I'm so passionate about doing these sessions to kind of bring like-minded people together. And then a whole cocktail of emotions that you might be feeling. Now, we have this technique called ALBS, and you can use ALBS to validate your own emotions and start to look at pathways forward, as well as reflecting on your loved one's emotions. So ALBS is another acronym, but again, it doesn't need to be used in this order. So noticing visible signs of distress, so first of all with yourself, labeling the emotion. Well, you know what your own emotions are. Sometimes it's confusing. Is this anger? Is this sadness? Is this shock? Validate with the word because, and there's lots of research behind that. So I feel angry because, rather than I just feel angry. And then soothing. So each emotion has a corresponding need from the environment. And soothing is in various stages. So it might just be, first of all, taking a breath, talking to somebody, and then thinking about what next steps might be. Okay, so thinking about this this carer, I'm caught in this terrible trap of watching my daughter all the time. I've even resorted to reading her diary. Labeling the emotions, total desolation, utter sadness, despair, hopelessness, guilt, lost, alone, and numb. And then validating, well, I feel overwhelmed and totally desolate because my beautiful daughter is so ill with her anorexia. And I feel utter sadness because my daughter feels compelled to hurt herself, both with starvation, overexercise, and now cutting. And I feel despair because I'm powerless to make things better for her. I feel numb because I cannot bear the physical pain that comes with all these emotions. So very common responses. And then thinking about soothe. So this might be a framework. These are the ways I can self-soothe. So you'd all have different things, but maybe go for a walk, do some exercise, listen to music, read, watch TV, have a cup of tea with a friend. Who are the close others? So these are close others who maybe can help me to soothe. Maybe my mum, my sister, my best friend, other carers at a carer support group or a workshop I've been to. What might they do? Maybe they can distract me, give me a hug, help me to review and reflect on what's been happening, and maybe what I might do differently in the future. We talked about this in the carer workshop or the carer support group, and other carers have felt similar. They feel the same, and it's somehow soothing to know I'm not alone. It's a big message here about not being alone. It's okay to have these feelings, and they can be overwhelming at times. I'm doing my best, and that's good enough. I'm learning so much, both about eating disorders and self-harm. I'm learning so many ways to connect with my gorgeous girl, and the balance being paying more attention to things that are going well for her. Okay, so thinking about some of the reflections from young people. So some of these are from the video you just watched. I don't want to be watched constantly. I don't want people to see me as that person. So not being labelled as a self-harmer. My mum and dad accepted it. They didn't shout. They gave me support. I'll be forever grateful. Before I didn't have aspirations. Now I see a future. It was such a weight off my shoulders being able to communicate more with my family. This has been a very positive step for me. So those very kind of hopeful responses from the person who's opened up about their self-harm. And then these are the caring responses. I knew about self-harm, didn't expect it to happen to my little one. Trust yourself, you're okay as a parent, just keep talking, that's fundamental. It's important to get professional help if you can. Often the first port of call is the GP. There's lots of resources at the end of this video that give you lots of different options. It has to be when she's ready on her terms. So really having the patience of a saint. And of course, that's hideously hard. Some more tips from young people. So try not to judge. Be honest. I don't understand. I do want to help. So if we've never used self-harm as a coping strategy, we can't totally understand, can we? Accept recovery is a process. It's not linear. It will take time, for some longer than others, and really, really paying attention to what's going on for your loved ones. So really listening, both to what they're saying, but reflective listening isn't necessarily that they've spoken something. It might be that you're noticing what's going on for them, their body language, and so on. And talk about other things too. So, you know, more attention to the blue balloon, what you're proud of, what makes them such important and valuable members of your family. So this is a quote from a young person. My mum took the time to listen, really listen. She made time for me. I was the most important thing she had to do right then. It made me feel special and allowed me to open up to her. Okay, these are some more quotes. I think some of these are from the professional video, but they're really relevant. So everything going on inside me is really ugly and really scary. So if you react badly to what's on the outside, I'm not going to show you what's on the inside. So building up that trust is so important. To have that trust is crucial. There are hard days, but there's always light at the end of the tunnel when you have someone you trust. So trust is really at the core of all of this. Okay, now a question that we don't naturally think of asking would be, what are the benefits of this behavior? So what are the benefits of your eating disorder behaviors? What are the benefits of your body dysmorphia strategies? What are the benefits of your self-harming behaviors? So we really are trying to come to where our loved one is. So there's an expression, isn't there? Every behavior has a positive intention. So you're seeking to understand some of the things that keep self-harm going. And you can ask the same question with the eating disorder behaviors and the body dysmorphia. So often young people say this sort of thing, well, it gives me control. It makes me feel in control. And if I feel in control, I feel safer. I'm good at it. And often people who are self-harming become really good at addressing their wounds and looking after their wounds. I get attention. It's the only way I can communicate my distress. I get a feeling of euphoria. So in that moment, you know, the endorphins give me that feeling of euphoria. It's my release, makes me feel calm and focused. The physical pain is easier to bear than the emotional pain. That's a very common one. It wipes away bad feelings. It makes me feel alive. So if someone's feeling very depressed and, you know, maybe veering towards suicidal ideation, it makes me feel alive. It keeps me alive. Without it, I would die. I like the sight of blood. It makes me feel alive. So these are common responses when a young person is asked. So can you help me understand what keeps the self-harm going? What are the benefits of it for you at the moment? Now, if you had a coping strategy that gave you all these sorts of benefits, how much would you want to give this up? So this is empathy again, isn't it? So we're really connecting, coming to where the person is. And then the next stage of this is the decisional balance that I mentioned when I was talking about the contemplation stage. So when somebody's in two minds, so part of them wants to move away from their self-harming behavior, but part of them is very wedded to it because it's a coping strategy that's effective for them at the moment. So the first quadrant is the one we've just looked at. I wonder what the benefits are. The second quadrant is the one that our mind automatically goes to. Are there any disadvantages to your self-harming, or what are the not so good things about your self-harm? Okay, and then the third quadrant is the most important one. So we go around this quadrant in this kind of clockwise direction. So thank you for helping me to understand more about the benefits and the disadvantages of your self-harming behavior. Help me understand what might stand in your way of letting go of your self-harming behaviors. And then the fourth quadrant, again, which is what we as parents and carers would automatically want to be thinking about, but our loved one might not be there yet, is what might be the benefits of letting go of your self-harming behaviors. Okay, so these are the quadrant one we've just looked at. Quadrant two might have these sorts of things. Well, it's painful. I have ugly scars. My friends and family hate it and get upset. I feel guilty and ashamed. It's getting worse. It makes me isolated. Maybe I put friends in there. Maybe my friends push me away because of it. Okay, and then what might stand in your way? Well, it's my coping strategy. I don't have anything to replace it. I would feel out of control. It's the only coping strategy that actually works at the moment. I would lose the attention I've been getting. I can't imagine not doing it. I would have to face my emotional pain because at the moment it's my way of numbing the pain. I'm scared I wouldn't be able to cope. I would have to communicate my pain in another way. And at the moment, I don't know how. And then what might be benefits? So my friends and family would be happy. I could wear clothes that show off my arms and legs. I wouldn't have to hide away the whole time. Maybe I could be in a relationship. I could be proud of myself. I could plan a future. Life in general would be so much better. And everyone's different. So some of your loved ones might immediately be able to talk about the pros of change, but some of your loved ones would say, I can't imagine it. I can't even imagine that. At the moment, it's a really important coping strategy for me. Okay, so often the roadblock to letting go of self-harm or any of the eating disorder or body dysmorphia behaviors is basically fear. So maybe fear of failure, fear of the unknown, fear of how I will cope. And that fear can be paralyzing for our loved ones. So we need to respect that fear, and we can be curious about that as well. Now with James, who we suspect is taking anabolic steroids, so I'm not going to read all these out, but several schools have asked me to do sessions around anabolic steroids for staff members. And so I created a decisional balance around anabolic steroids. So you've got the benefits of taking anabolic steroids, the potential disadvantages. So you've got many things there that teachers maybe would automatically try to argue with logic, and then they would disengage with the person, a bit like in the video, the young lad in the first response, you're not doing anything silly, are you? So he just left and said, oh, it's fine, I'm fine. What stands in the way, so his fears of what he might lose if he gives up anabolic steroids. And then finally, what might be benefits of letting go of your anabolic steroids. So let's say that James, in our example, isn't ready to stop taking the anabolic steroids. He's very fixated on that quadrant 3 of all the things he might lose if he seeks help to stop taking the anabolic steroids. So we're really trying to get into his mindset. So let's have a look at 4 different scenarios. So James has disclosed now, you've built the trust with him. He's disclosed he is taking anabolic steroids. He's become very upset. He refuses to look at you and is very tearful. Hayley shows you fresh cuts on her arms. They look clean and shallow. So she's got no visible signs of shock. So it's not any medical emergency. Chloe is very open about her self-harm, both online and in school. She doesn't cover her many scars. Her friends find this very awkward and push her away. Tice comes to you crying and clearly very distressed. They've recently identified as non-binary and is struggling to find their tribe. They say they've taken a packet of paracetamol, but they don't want to die. So you've got 3 quite distinct examples here. So always, is there an immediate need for medical care? Is the young person a danger to themselves? What message do you want to give the young person? Okay, so first aid, call an ambulance or go to A&E if necessary. Wound management would be the first things you might be thinking about. But if you know that your loved one is very good at tending their wounds, there's no medical emergency, then what is the message that we need to give the young person? So let's think about Hayley first. So she shows you fresh cuts on her arms. They look clean and shallow. She's no signs of visible shock. So thank you for telling me, thank you for showing me. So a lovely softer affirmation. You're not in trouble, maybe, because often young people think that they're going to be in trouble. We're here to help you. Or if you think that that might be a bit triggering for them to say you're not in trouble because they don't feel they're in trouble anyway, you might say, you know, this is a topic we can talk about. We can support you within the family, or in a school setting, you might say you're safe in this school, for example. So let's unpick more about noticing and validating the emotions. And I'm sure most of you have seen the Pixar movies Inside Out, where there's all about the emotions running around in Riley's head, first of all as a child, and then in the second one as an adolescent. And this film was put together with child psychologist input. And there's a couple of links there of one book and a website that really talks more about this concept of focusing on the emotions as a really good way to connect with a young person. Now let's think about a bit of science as to why this might work. Now there's many hormones in the teenage brain, in the developing teenage brain, and they're much more volatile than the adult hormones. So we have these as well, but 2 of the most important are serotonin, which is the happy chemical, and dopamine, which is like the reward hormone. Okay, now in an ideal world, for humans to be emotionally regulated, then serotonin and dopamine are tracking along at about the same level. So you can see before 9 years old, they're about the same level. After about 20 or 25, they're about the same level. But you might have heard of the dopamine spike or the dopamine rush. Now, this is why teenagers are programmed to make high-risk decisions with poor judgment, some more than others. So get a group of teenage boys together, they're more likely to adopt risk-seeking behaviours, as an example. Okay, but they need to, this is part of growing up, they need to be moving away from the family setting and going out and exploring the world. And that entails taking some risks, doesn't it? And the adrenaline and endorphins that come from some of this kind of going out into the big wide world. Now, it's more like this hedgehog, if you like. So the daily variability of the hormones in the teenage brain is probably plus or minus 25% a day. In adults, it's more like plus or minus 5% a day. So you've got this, you know, this hedgehoggy-like spike of dopamine, and also serotonin's daily variability is about the same, but you've got this kind of difference here. Okay, now, sorry, just going back to serotonin, we know that 93% of the expression of serotonin is managed by the gut. And the thing that triggers the cascade to boost serotonin in your brain is by eating carbohydrate in combination with foods that have tryptophans in, so things like chicken and eggs. So our brain is really clever, isn't it? So when we've had a bad day, whether we're adults or children, our brain says, give me more serotonin. So basically it says, give me carbohydrate. And that explains comfort eating, doesn't it? And you don't have to eat very much of carbohydrate before you start to feel a bit better. So that totally helps us understand comfort eating. Now with dopamine, it's not the same. So 93% of the expression of dopamine is managed by the limbic emotional part of the brain. So right at the very middle, you've got the amygdala, you've got the hypothalamus, you've got the hippocampus, all right there in the middle. So that's what we call the limbic emotional part of the brain. So if 93% of the expression of dopamine is managed by the emotional part of the brain, it makes sense then to pay attention to emotions, doesn't it? So look for the emotion behind the behavior. And then at the same time, if we can drip feed these affirmations, whether they're big character strengths or whether they're softer affirmations, that really helps us to boost self-esteem and really connect with the child. So it's almost like buy one, get one free. And that's just the science behind this technique, that the ALDS technique that works really well. Okay, so thinking about soothe, then soothe is multifaceted in this model. So carers often say, so we've all seen this picture, haven't we? We've probably drawn this picture ourselves of the house with the windows and the door and the chimney and the windy path. And carers often say that we all, for the whole family, we feel like we're outside the gate and the gate is locked at the bottom of the path. So how can we even peer over the path? So this is what we mean by soothe, is we're connecting with the person and then we're helping them to peer over the gate to see a pathway forward rather than feeling stuck. Okay, so part one is often just a hug and empathy. Now, sometimes your loved one will push you away. They don't want a hug. Their oxytocin levels might be a bit depleted, but we can give them a verbal hug, you know, and those softer affirmations. Then there can be the big words. Distractions can be really helpful. So blue balloon type distractions, you know, whatever you know that they're interested in or that you know is soothing for them. And that concept of team family. And also within that concept of team family, our belief that they can start to move forward with our support. And then later, so we say when the iron is cooler or when the iron is cold, because when they're really emotionally distressed, their prefrontal cortex is kind of flipped. It's called flipping your lid, isn't it? So they're not able to process what you're saying to them. So later you can help them to start to visualize future pathways. And we're going to have a look within the context of self-harm at this with a very simple 5-step model for change. So simple example, Mummy, I have a tummy ache, I'm not going to school. So your automatic response is probably, it's busy Monday morning, you're all trying to get out of the house. It's Monday morning, you always have a tummy ache, you have to go to school. Or, I'm sorry you have a tummy ache, is everything okay? You seem sad. So you're noticing the emotion. You're reflecting in noticing the emotion. So how do you soothe someone who's sad? Well, maybe you give them a hug, and then maybe something like, I often feel like that on a Monday morning, and it can really help to drink a nice cup of tea and eat some breakfast. So this is going to take a few minutes longer than you need to get in the car because we have to get to school, or you need to run for the bus. So you're making the connection, soothing with a hug or a verbal hug, and showing empathy that the child is struggling. You experiencing that too sometimes, and then the child is more likely to go to school. What about this one? You're not listening to me and you don't understand me and I hate you. And the person runs out and slams the door. So like a fizzy Coke bottle. So you know that you can't connect with them in that moment. In fact, they physically left the room. But what might the emotion be? Maybe it's anger, maybe it's frustration. So maybe How do you soothe someone, give them some space, and then later when they come back, reconnect with them. And this ALDS technique can be really, really useful for that. So let's go back to Hayley. So you were so shocked to discover that Hayley had cut herself that you panicked and said in a distressed tone, "Hayley, what have you done?" And she responds, "You're not listening to me and you don't understand me and I hate you." And she runs out, slamming the door in your face. So you want to reconnect with her later. So you're going to be feeling pretty bad about this. How could I have responded differently? But you're human. Sometimes we are going to be shocked and be panicked. Okay, so it's all about that reconnection. So maybe this is later on a walk, or maybe, you know, back down in the dining room or something, probably one-to-one, not with other people in the room. "Darling, I can see my reaction to you earlier was really unhelpful and you really slammed the door when you left the room, but said with no hint of criticism or judgment. I'm guessing you were angry and frustrated. We can only guess, but if we guess wrong, it's likely that Hayley will say, no, I feel this." And then using the word "because." "I'm guessing you were angry because you feel I was not listening." So we can use Hayley's exact words here. "Frustrated because I don't understand you. I would feel angry and frustrated if I felt nobody listened or understood." And then soothing can be multifaceted. Okay, so we'll come back to the soothing. Let's think about a crisis situation. So Tice comes to you crying and clearly very distressed. They've recently identified as non-binary, struggling to find their tribe. They say they've taken a packet of paracetamol, but they don't want to die. So thank you is an indirect affirmation. Tice, thank you for telling me. I can see how upset you are. You seem really anxious and absolutely terrified because you've taken paracetamol and you're scared about what's going to happen next. These are normal feelings for somebody in this position. And then the soothing is going to be straight away here because this is a medical emergency. I'm going to help you. This is what's going to happen next. I will make sure somebody's with you every step of the way. We'll take 1 minute at a time. Okay. And then hopefully when the crisis has subsided, so Tice is home from hospital, not suffered any long-term effects from the paracetamol overdose, they ask you to help them get back on track. They tell you they've lost their self-confidence, often get overwhelmed with negative thoughts and feel very isolated. So attend. So repeating, reflecting on what Tice has said. You feel overwhelmed with negative thoughts, you've lost your self-confidence, you feel very isolated. You seem extremely anxious and depressed at the same time. And then the validation, you're feeling extremely anxious because you've become distanced from your friends since you identified as non-binary and you feel unsure how you will find your tribe. You're feeling depressed because you haven't been able to do your blue balloon, acrobatics and dance maybe since you were diagnosed with anorexia. And that's always been the thing that's made you feel a sense of belonging and also a sense of achievement. And then maybe a bit of normalization here. Lots of young people are really struggling at the moment, but without dismissing Tice, you're not alone. We're here to help you get your life back on track. You're such a talented person. Your close friends have always valued your sense of justice. And then maybe later, we can make a timeline for the next few months to visualize happier times ahead. Okay, so let's go back to James. So James is now in two minds, maybe. So James has started to trust you more, that you won't judge or criticize him. He's disclosed he is taking anabolic steroids and has become very upset. He refuses to look at you and is tearful. So James, I notice that you're avoiding eye contact with me and it looks like you're feeling upset. You seem sad and anxious at the same time. Maybe you're feeling this way because you've opened up to me about your steroid use and you don't know what's going to happen next. So this is really common, the fear of what's going to happen next. Thank you for telling me. It's a very courageous thing to do. And I'm so pleased you feel you can trust me. You're not in trouble. You're safe in this family and we can help you. Okay, and then thinking about the soothe. So later, maybe when he's a bit calmer, so there might be a break in the conversation, there are several options and we can make a plan together. I've been reading about things that have helped other families. So this is really powerful. Rather than mum or dad going in with, I think we should do this, just saying, well, you know, there's options, maybe asking James what he thinks. He's likely to say, I don't know. Then making it more from third party. So I've been reading about things that have helped other families. Would you like me to describe some of the things that have worked for them? Or would you like some space to think about what you would like to happen next? We can always talk about this next week. I know you usually go to drama club at this time and you're such a good role model to the younger kids. So indirect affirmation there. And then when he's opened up to us, so there's trust there, we can turn up the heat a little bit. So we call it developing discrepancy. And we can understand how this works with Aesop's fable of the sun and the wind. So we all know the fable, don't we? The sun and the wind are having a battle to get the man to take his coat off. The north wind goes first, blowing and blowing and blowing really hard, and the man just holds onto his coat tighter and tighter. And the sun has a very different approach. So the sun shines gently down. So think about building that trust, the connection. The man relaxes, but the man doesn't take his coat off. So what does the sun have to do to get the man to take his coat off? It has to turn up the heat enough to make the man a little bit uncomfortable, and then he'll take his coat off of his own accord. Okay, so that's what we start to do with this developing discrepancy. So James, there's a small part of you considering making changes, and at the same time, you feel nervous, scared, anxious because you've experienced many positive effects of taking steroids, which you're not entirely sure you want to lose. So you're acknowledging both sides, but you're sowing the seed for James that change is possible. Okay, so thinking about later stages of recovery. So Chloe is weight restored. So maybe she's been on her anorexia refeeding program. She's stopped self-harming, and she's recently been very open about her history of self-harm, both online and in school. She doesn't cover her many scars, and her friends find this awkward and push her away. It's a very distressing situation. So again, thank you for telling me. I can see how difficult this must be for you. I imagine this makes you feel frustrated and angry. Frustrated because you want to be able to trust your friends to accept you as you are without judgment. Angry because there's still so much stigma around eating disorders and self-harm. Let's cuddle up on the sofa and watch that documentary you told me about. Chloe, you've come so far, and the volunteering you're doing for BEAT will help so many other young people who are still in the midst of their illness. We're so proud of you being willing and able to help others, even when you're still facing some of your own challenges. So you can use these techniques maybe long after a young person has maybe been discharged from services or their therapy's finished. We can still use these techniques in the family to carry on with that support. Okay, so with the language, then the things that, you know, summary kind of page here. So we're really, really thinking carefully about avoiding any hint of criticism, hostility, arguments, judgment, or just rushing in to tell them what to do. I think you should do this. And instead, we've got a different dynamic, haven't we? So really listening and paying attention to what's going on for them, always thinking to reflect back, showing empathy for the challenges they're facing, noticing their emotions, drip feeding those affirmations. And if we're going to ask questions, try to ask open questions. And we have these couple of mantras here: be curious, not furious, strike when the iron's cold. So try to have conversations when things are calmer. So this might be out in the open, you know, fresh air, might be driving in the car, basically calm moments to try to explore. Give more attention to the behaviors you like. And that doesn't mean that you can't agree boundaries. So you can still, you're still the parents, aren't you? It's still the carers in that supportive role. So you can still agree boundaries and be firm with some of the maybe lingering behaviors, or sometimes when there's violent outbursts, but always we've got that compassion and empathy for the challenges that they're facing. So the final part of this is looking to the kind of solution focused moving ahead. So this has to be when your loved one's ready. So 5 steps, very, very straightforward. So step 1, helping the young person to think about behaviors they might want to change. I like a spider diagram, can just write a list. Step 2, help the young person to think about difficulty to change. So if there's no compelling reason, we would always guide to go for an easier one first. And they might change their mind a few times, but sometimes there's a medical or a social reason to go for a harder one first. Step 3, we can unpick any behavior using what we call an ABC approach. So every behavior has antecedents or consequences, and that can be a really good way to explore where the person is, you know, in terms of maybe there's some obvious things that they could start to change themselves. And we can be curious. We've got some other techniques that if you go to my website, you can see some examples of other techniques. Step 4 is think up a kind of experiment. So we call them behavioral experiments, to try to start tiny steps towards moving towards change. And then step 5 is every now and then reviewing and reflecting with the person. So EDI is the person with the eating disorder, and helping them maybe to adjust their expectations. Maybe it was too big a goal. Maybe it was too small a goal and they want to move faster. So it's kind of a fluid process. So this is an example maybe of someone who's said, so these are my features of self-harm. So there might be only one, or there might be lots of different ones. So in this one, there's lots of different ones. So I'm not going to read them all out, but you can see there's little blue balloons there with kind of the numbering. So this is percentage difficulty to change. So in this case, the young person has said, well, one of the things I do is relentless pinching of my stomach and arms and thighs, and maybe that's leaving little cuts and bruises. But that really serves a purpose for me. So that would be 100% difficulty to change. So I'm not going to try that one. Maybe banging my head. Well, I need to do that because it's the only way that I can quieten the eating disorder voice. So that's 100% difficulty to change. And then you've got several there with 80 to 85% difficulty to change. So the idea is that we're guiding our loved one to choose which one they would like to start with. So let's say in this case, the person says, I'd like to think about the cutting my arm with a razor, and has got several reasons of why they want to choose this one. What are the antecedents? Well, basically, it's a stressful day at school. And what are the consequences? Well, when I'm having a stressful day at school, I get immediate relief, but then later I feel anxious again and the cycle goes on. Okay, so let's go back to Hayley. You've built trust with Hayley, who wants to consider reducing the cutting. She's now ready to look at possible alternatives. She asks you to help her come up with a list of options, and you both maybe research this together. So we've got a whole list here. So you could use this list as a framework with your loved ones. So create a crisis or an ideas card with the aim of delaying the urge to self-harm when her anxiety is building. There's lots of downloadable safety plans. So this is just one example. So create my own personal safety plan. Create a list of healthy alternatives to self-harm and consider trying to introduce one new healthy option a week for the next 4 weeks. So this has to be led by Hayley. We can't just go in and say, you should try this alternative strategy, because that's not understanding or being empathic about the difficulty of moving away from self-harm to something else. There's lots of soothe boxes. So this is an example, a hope box resource that lots of young people find really useful. So it might just be a shoebox that's got various things in, might be nice kind of things to squeeze or touch. It might be hand cream. It might be something creative like a crochet set, anything like that. The Calm Harm app is really popular, so we're going to look at the how the Calm Harm app might be used. So it's a free NHS app, and it's based on techniques called dialectical behavioural therapy, which are really successful with self-harm. Maybe have a checkup with the GP, and then think about local areas of support. So these are a couple of links here, but also there's another resource page later on with links in Sussex. Maybe research private therapists if that's something that your family has the ability to research into. Okay, so when somebody's got a menu of options like this, they feel less hopeless because they can choose one to have a go at. They don't have to do them all. If one doesn't work, they can come back because there's more than one thing on the menu of options. So this is where this can be really, really successful. Okay, this is maybe the crisis card or things I will do when I'm feeling really anxious. So it might be things I can do at home. There might be a separate one, things I can do out with my friends. Might be a separate one, things I can do at school. And the idea, maybe this person has them on her app or has little cards. So when I feel really anxious or stressed, I will do a counting exercise, text or call someone, eat something really sour, kind of get that distraction, watch YouTube videos of mini Dachshunds, go to student support, call a helpline. Okay, so, but there could be, as I say, various different options. Then thinking about, maybe Hayley says, let's have a think about that Calm Harm app. So she does a bit of research. She thinks, oh yeah, maybe that would help. So we can use this stepladder approach to support Hayley. So the idea is, it's called an anxiety hierarchy, but it's just think of it like a stepladder. So the idea is that the overall goal is at the top. So Hayley says, I want to use the Calm Harm app to stop my self-harm altogether. So the first step, she says, well, I'm going to watch a video for young people. So I'm going to show you the video in a minute. And then the idea is that the expected anxiety is likely to be quite high because she's starting to move towards change. But then when she tries these things, maybe they're not quite so anxiety provoking. So she watches the No Harm Done video. She's predicting an anxiety wave of 50, but it's only about 20. She found it really reassuring. So then she's ready to go to the next step. Maybe talk to my mum further about stopping self-harming. Again, really difficult to think about talking to my mum, but actually, as the young lady in the video said, it was such a relief to have it out in the open. So anxiety was much lower having spoken to her mum. Then maybe talk to my mum about the specific Calm Harm app, so maybe share it together. Hayley's was like, yeah, I was nervous. It might be rubbish, but my mum was supportive, so we can look at it together. Agreed that she will use the Calm Harm app on Sunday, doesn't matter when it is, but specific, on Sunday for 5 minutes. So Sunday, because it's her least stress day. So Sunday is my least stress day, but I did get anxious and it did help. For a few weeks, continue with this step. So gradually, by repetition, the anxiety around using the app starts to come down. So Hayley's saying, well, using it at home, it does help a bit, although I'm not sure if it would work in school. So the next step might be show the Calm Harm app to my friend at school. And then often on this step ladder, often what happens is that a step proves too much. So I've put it red here because what happens is Hayley couldn't do it. She was terrified of being judged. So she would feel like she's all the way back to square one, but we can support her to, when she calms down, we can remind her that, you know, she's really determined to do this, that she's already made such progress, that maybe that was a step too far. No pressure, you know, maybe wait a week or so before going back to it. And then the idea is to come up with an incremental step. So maybe something that's in between the one that was too big a goal and the previous step that was successful. So in this example, show the Calm Harm app to my friend at home on Sunday, because Sunday is the least stressful day. And also it's at home, not at school. So it's a very different situation. And this time it turns out, okay, my friend was really supportive. She has a cousin who self-harms and she didn't judge me at all. So, and then as many steps are as needed, that Hayley would keep using the Calm Harm app to gradually build confidence, and ultimate goal to stop self-harm altogether. But for some people that might be a very quick process, and for other people it might take much longer. But it helps you to see kind of an illustration of this stepladder approach that can be really, really useful. So this is the video aimed at young people.
It's a place where you can be.
You probably feel better at the time, but then the guilt sets in, then it's just a cycle, because it never really makes the emotion go away. Although it's a coping mechanism, it's very much like in the moment, and I did feel more isolated because I wasn't able to tell anyone for quite a while, and I started to feel quite lonely. It's not something you really want to admit, that you've got so low that you're having to resort to something like that, because there's lots of stigma around self-harm. No one noticed. Like, I probably could have not told anyone ever and kept it like quiet. So when I started being able to open up to people, it did make a massive difference, because talking about it is much more positive than actually doing it.
It was kind of a relief that I'd spoken to somebody about it. It's just the little small things that can make big impacts. I was helped to find other ways in expressing myself without hurting myself. You find out different ways that you could get help and different places where you can go. It's a place where you can be heard in a space that you feel comfortable, that you could actually speak to professionals or people that you trust about it.
One of the most positive things is change. There are things that will make things better, and you just have to look for them. And if one thing doesn't work, that doesn't mean you should give up or you're not worth it. It means that there are other options which you haven't yet explored.
Getting help made me realise I'm not alone. I felt so alone, I felt so isolated, that having that help opened my eyes to the fact that I can get through it. And my most amazing thing is that I can take my negative experiences and turn them into something positive.
Okay, now the final part of this presentation is around exploring alternatives to unhealthy coping strategies. Okay, but only when the young person is ready. So there's lots of self-harm minimization strategies. So again, this is taken from the mental health first aid program around self-harm. The important thing is that we're not trying to impose this or push our loved ones too quickly. So if your loved one's unsure, maybe show empathy and be patient. But sometimes it can be useful maybe to say, oh, you know, I've seen that these are some useful self-harm minimization strategies, and I wonder if, you know, any of those, that there's a possibility that you could try any one of these. Okay. Now there's a separate PowerPoint which I can share as for information by the lovely Pookie Knightsmith, who's written much about eating disorders and self-harm. And she created a PowerPoint of 130 ideas of alternatives, and she categorized them into all these different areas. And some young people have found it really useful to print off the pages of the PowerPoint, and then they go through and they say, oh, that might work, that wouldn't work, that wouldn't work. And then it might prompt them to come up with their own ideas as well. So these are, you know, we need to be very careful not to impose this on the young person. We're just helping them to pursue and think about possible options. Okay, and then really overall thinking of three main things. So self-harm is a coping mechanism, so we can't just say stop. Trust your gut. So if you're worried about medical risk, or you know, that you need to go very quickly to the GP or to go to A&E or call an ambulance, trust your gut. So follow up and bring in outside services if you feel that there's an emergency. And then the third is always really paying attention and listening and asking, how can I help? So unconditional love, how can I help? Okay, and then you as carers and parents, role modeling self-care as well is really important, and this is really hard. So looking after yourself. I know when my son was first ill, I found this impossible because all of my energy was focused on trying to get him help. So noticing and validating your own emotions can be really, really soothing. Accepting that this takes time. It's not a linear getting from A to B. It's a process that takes time, and you need to be physically and mentally well to support your loved ones through this. I'm just thinking about some of the wellbeing basics. So again, I needed to put things in my diary to make sure I did them. So whether it was around eating or sleep routines or exercise, getting outside, connecting with others, because it's so easy for the whole family to become very isolated, and really thinking about the blue balloon for the whole family. So really scheduling fun activities with all the members of your family. These are some local resources for professionals supporting young people, but as parents and carers, you can go and have a look at these pages as well. Sorry, and this is the video for professionals. If you're curious, you might want to go and watch that as well. This is the new resource for schools. And again, you might want to go and have another look at this website and see what the resources are. These are further resources for young people who are self-harming. So I've shown you the video. Alumna is a 7-week course offered online and free for 14 to 19-year-olds. So you've got the link there on the self-harm website. The Calm Harm app we've already talked about. And then Pookie Knightsmith has written a small book. She's written a bigger book for schools about self-harm and eating disorders, but this one is just, Can I Tell You About Self-Harm? Which can be used with siblings aged from about 7. So it's very useful to explain to other members of the family, maybe. Resources for parents and professionals. So the No Harm Done videos. This is a workbook based on cognitive behavioral therapy, which is really useful. So it takes you through quite a few of the kind of exercises that we've looked at in this session, but there's more things to have a look at as well. This is the book for schools by Pookie Knightsmith, which is very good. And then a couple of books around validating emotions. So the first one, it weaves in dialectical behavioral therapy skills that are used within the Calm Harm app as well. And also the What to Say to Kids When Nothing Seems to Work is very much around that ALBS technique that we've been looking at. This is a picture of my son who, when he was fully recovered, and he just played football in a football final, and they'd lost, but he was still happy. So he was becoming more resilient all the time. And this is the link to my website. So I've got a network of over 1,200 families and 400 professionals. So, you know, any of you can contact me and join my network if you would find that useful. Okay, thank you very much. So I'm going to stop the record. Oops.